Good morning. I'm Marcus Plusha, the chair of the National Forum for Heart Disease and Stroke Prevention, and I'm also the chief medical officer at the Association of State and Territorial Health Officials. Welcome to the 2024 annual meeting. Today's meeting centers around the theme, Advancing Health Equity Throughout America, Novel Data-Driven Approaches to Cardiovascular Health. It's been an honor to serve as the chair of the National Forum for the last 2 years. And I'm pleased that the National Forum has continued to increase and document its impact on cardiovascular health and health equity. The National Forum was recently honored to receive the Association of Black Cardiologists' Spirit of the Heart Award. The Association of Black Cardiologists produced a video for this awards, which was shown at the awards gala. And we'd like to quickly show that video as it gives several examples of our impact.
The National Forum for Heart Disease and Stroke Prevention is deeply honored to be selected by the Association of Black Cardiologists in receiving the Spirit of the Heart Award. Co-founded in 2002 by the Centers for Disease Control and Prevention, the American Heart Association, and the Association of State and Territorial Health Officials, the National Forum's mission is to spark and lead collaborative action to achieve health equity and optimize cardiovascular health and well-being throughout the lifespan. The National Forum is comprised of more than 100 member organizations representing the public, private, and nonprofit sectors. The National Forum pursues its vision that people throughout society live heart-healthy, stroke-free lives by fostering collaboration among the most dynamic and diverse organizations in cardiovascular health to share successful strategies, practices, and lessons learned, discuss new ideas in collaborative environment, develop, pilot, and scale innovative approaches to prevent cardiovascular disease. The National Forum's major initiatives, in which ABC has provided leadership on and is a valued partner, include the Value and Access Collaborative, a multi-sector collaborative bringing together patients, providers, payers, purchasers, public health, and pharma and biotech, supporting people's access to evidence-based care that is appropriate for them. In 2021, the Value and Access Collaborative developed policy recommendations to expand access to evidence-based care provided by pharmacists. Between 2021 and 2023, 32 states enacted 75 laws aligned with the policy recommendations. The Value and Access Collaborative also develops shared decision-making guides to help healthcare providers engage in conversations with patients about treating and preventing cardiovascular disease. The Mayo Clinic found that guides on FH resulted in a 50% increase in patient engagement. Over the past decade, through its Move with the Mayor initiative, the National Forum has mobilized a network of more than 200 mayors to encourage active, healthy living and strengthen individual and community resilience. Mayors use Move with the Mayor messaging, program policy and infrastructure recommendations, and other tools to empower and protect community members from health threats and improve cardiovascular health, mental health, and health equity through co-branding partnerships on initiatives including Move with the Mayor, Know Your Numbers, and Community Pharmacists. The National Forum collaborates with clinician partners and members to amplify information on important health issues impacting cardiometabolic health, including physical and mental health, vaccination, and patient-centered, team-based care. These paid social media ad campaigns exceed national engagement benchmarks, reaching community members far and wide. The National Forum looks forward to continuing collaboration in 2024 and beyond to advance policies and systems changes that improve cardiovascular health, overall health, people's well-being, and health equity.
As we look to the next 2 years and beyond, the National Forum continues its thought leadership role in empowering all of us to help people throughout America understand that health equity benefits everyone. This meeting is part of that initiative. Before I introduce our keynote speaker, here's our Executive Director, John Clymer, with some announcements.
Thank you, Dr. Plesha. Good morning. Here are a few ways to help you maximize your engagement and takeaways from today's meeting. Please use the chat function to comment on the meeting topic, panel discussions, and share information. Helpful tips and links will also be included in chat. Use the resource feature to access the program book with the agenda, speaker bios, and more. Use the Q&A feature to ask questions. Please submit questions at any time. Following each panel, we will have a Q&A session during which our panelists will respond to as many of your questions as time allows. When sharing key points from the meeting on social media, please use the hashtag #NF2024, NF2024. Panelists' X or Twitter handles will appear on screen and are in the program book. Closed captioning is available, and you control how it appears on your screen by using the CC button on Zoom. Today's meeting is being recorded. If you have colleagues who can't be with us right now, they can catch the whole meeting on demand next month. When the recording and meeting summary are posted, the National Forum will send you the link. This convening and your no-charge participation are made possible by our generous sponsors. Thank you to the American Heart Association, American Pharmacists Association Foundation, Boehringer Ingelheim, and Regeneron. Toward the end of the meeting, National Forum voting members will elect Board of Directors members and take part in a very brief business meeting, and the National Forum will present awards to individuals and organizations who have made exceptional contributions to improving cardiovascular health throughout society. Now, Marcus, back to you.
Great, thanks, John. So now we move on to an important event in our agenda, our keynote address and keynote speaker. And it's my honor to be able to introduce our keynote speaker. Admiral Rachel Levine is the Assistant Secretary for Health and the head of the U.S. Public Health Service Commission Corps at the U.S. Department of Health and Human Services. Dr. Levine is a pediatrician who previously served as Pennsylvania's Secretary of Health. I go on to say Dr. Levine is also the former president of the Association of State and Territorial Health Officials where I work, so I know her very well from that role. She took on that role as president at the very beginning of the COVID pandemic, and I really remember very well Dr. Levine's leadership and really instrumental support during that time, and that's leadership and support that she's definitely taken with her as she continued in her leadership role in federal government. So Dr. Levine, thank you for joining us, and thank you for being our keynote speaker.
Hello, and thank you for that wonderful introduction, Dr. Plesha. Congratulations on a successful 2 years as chair of National Forum's Board of Directors. I am pleased to address you all at the 22nd Annual National Forum meeting. The topic we have come together to discuss is one that is so important: cardiovascular health, and the role of the vital conditions that impact heart health and overall well-being. Heart disease is the leading cause of death in the United States for men and women and people of most racial and ethnic groups, but it can often be prevented. Encouraging individuals to live a healthy lifestyle can help prevent heart disease. This includes promoting healthy lifestyle habits, such as choosing healthy foods, maintaining a healthy weight, getting regular physical activity, not smoking, and working with health professionals to manage medical conditions such as high cholesterol, high blood pressure, and diabetes. These recommendations are easier said than done for individuals who do not have access to healthy options. Every person deserves the opportunity to live a full, healthy life. Healthy People 2030 defines health equity as the attainment of the highest levels of health for all people. And I firmly believe that we have not made progress unless we have all made progress. Achieving health equity requires that intentional work. That means making focused and ongoing efforts to end inequalities and the impacts of contemporary injustices, to eliminate disparities in health and health care, and improve the health for everyone. To achieve wellness, we have to do more than think holistically. We have to work holistically. In that spirit, I want to share an approach we call the People and Places Thriving Initiative. The initiative takes a holistic approach to human needs. As I have traveled across the country, I have seen the ways in which issues beyond the immediate scope of the United States Department of Health and Human Services influence the health and well-being of the people. Communities need more reliable transportation. They need more humane housing. They need more access to nutritious foods. They need economic justice, environmental justice, and climate justice. They need a greater sense of belonging and empowerment to effect change within their communities. Improving our nation's health and well-being requires addressing all of these needs. People and Places Thriving is a vision and an operational roadmap to build connections and support people in all ways that matter to them. It is not focused on new resources. It is about focusing on needed solutions and then pointing existing resources towards these solutions to maximize our combined impact. It is an evolution of the concepts we have often referred to as the social determinants of health. It shifts the focus away from limitations and restrictions for individual programs to focus on the totality of the capacity and capabilities that we have at the federal level and all other levels of public sector systems. It involves the full depth and breadth of the federal government. It creates a structure that leads to a shared vision and complementary actions across multiple departments. The framework is rooted in the 7 vital conditions for health, well-being, and justice that people depend on to reach their full potential. These vital conditions are the building blocks of a healthy, thriving society. We are seeing the power and value of the framework across many communities and systems. At the heart of vital conditions is belonging and civic muscle. This emphasizes the importance of healthy relationships and strong social supports in fostering thriving communities. It calls for federal, state, and local governments to collaborate with community members to strengthen community assets, connections, and values. The importance of inclusive belonging and strong civic engagement cannot be overstated. These are crucial elements in promoting resilience, strength, and equitable response within our communities. We must prioritize the development of local infrastructure that supports civic agency, collective efficacy, equitable access to information, vibrant cultural opportunities, and unwavering support for civil and human rights. Embracing and nurturing these values will lead to a more cohesive, empowered, and just society for all. To pave the way for equity, we must unite community leaders and advocates to act based on a shared vision of change. The National Forum's Move with the Mayor initiative mobilizes mayors nationwide to strengthen the vital conditions for health and well-being and justice in their communities. Through Move with the Mayor, elected leaders are empowering people to effect change in their own lives as well as their communities. These mayors are implementing evidence-based policies, programs, and environmental changes that enable people to thrive. Local elected officials are at the forefront of health leadership, and their actions significantly impact the well-being of citizens. They play a vital role in locally promoting community health and well-being, leveraging resources and networks to achieve health goals. Through public-private collaborations and national and local movements, HHS is working to actively achieve connections between public health and the vital conditions of health. That spirit of community is what makes our country great and is what we need now more than ever. All Americans deserve the opportunity to achieve optimal health and well-being so that they can thrive, so that our communities can thrive. We can do better. We must do better. And with your help, we will do better. Thank you.
Thank you, Dr. Levine, for that powerful and insightful message. As she reminded us, achieving health equity requires not just intention, but collective action. The People and Places Thriving Initiative and the focus on vital conditions offer us a clear path forward, one that prioritizes not only individual health, but the well-being of entire communities. Our first panel today will focus on addressing the vital conditions for cardiovascular health and well-being, origins and opportunities. Dr. Bobby Milstein, Director of System Strategy at Rethink Health and the Ripple Foundation, and a cutting-edge thinker and innovator in population health for most of this century, will facilitate all three panels today, guiding us through discussions that delve into the heart of these issues. Following each panel, we'll open the floor for a Q&A session, so I encourage you to think of questions as the conversations unfold. Dr. Milstein.
Well, thank you, John, and thanks to the National Forum for creating such a terrific space to explore the implications and opportunities for organizing around vital conditions. This is the first of three panels, all inspired by what we've already heard in a keynote address from Admiral Levine about why so many federal agencies are organizing their work around vital conditions and getting into different relationships with people and places all across the country. So we're going to explore in this session three big questions, and we've got three terrific colleagues to do it with. I'm joined by Dr. Ruth Thomas-Squantz from the Build Healthy Places Network, Dr. Shoma Saha from We in the World, Wellbeing and Equity in the World, and Bern Melnick from The Ohio State University and incoming chair of the National Forum. Together, we're going to explore some basic questions about what is the vital conditions and how does it build on what many of us think of as social determinants of health. We're going to spend most of our time thinking about the motivations that are driving growing use of this framework, and particularly among those that are focused on equity and racial justice, pulling out some standout examples that colleagues here have all seen in their work. And then we'll think together about the opportunities and obstacles for how to make the most of this framework when addressing the challenges of cardiovascular health. So what I'll do is just begin with a little bit of an orientation around the origins and opportunities around this framework. And the first thing to know is while the federal government has really been focused on this, as you've heard from Admiral Levine, since the pandemic, this framework has grown through thousands of collaborators across the country who have been looking thirsty for new ways of doing this work, and have been teaching us all about, sort of the possibilities of thinking and acting differently in ways that bring all of the players who can contribute to, equitable health and well-being into deeper, tighter relationship with each other. For our part at my organization is Ripple and Rethink Health. Everything we do is sort of organized around the idea of thriving together through shared stewardship. That means we join with others who want to realize this unifying, measurable expectation of all people and places thriving together with no exceptions. And we recognize that, our health and well-being relies on a system that is not built for everyone to thrive. But even systems fraught with racism, other forms of injustice, can be transformed through shared stewardship. And the key thing here is that everyone can be a steward. Every person, every organization, every network can play, pretty significant roles in shaping those conditions that affect our lives together. And so, with all of these players playing so many different roles, how do we begin to keep to keep the connections and the rising momentum of this work, sort of focused on shared values and shared actions. And this emphasis on conditions has been a part of public health and healthcare history for decades, right? We have known, and it has been reaffirmed again and again, that public health is what we do collectively to assure the conditions in which all people can be healthy. But decades later, we're just beginning to really agree on what those conditions are. There was a big step forward in the era of social determinants, sort of carrying the message worldwide that health is more than health care. But those of us who've been organizing around social determinants have found it hard to bring the full potential of every sector, every organization, and so many different walks of life into unifying action. And it was out of, sort of recognizing some of those strengths, but also shortcomings of social determinants, that a whole cast of characters has, over now almost a decade, been thinking of how can we get more specific about exactly what are the conditions that together we're trying to assure. And that is in many ways what the Vital Conditions Framework has become. It's really a statement not of the experiences of individuals, their own health and well-being over their life course, but the properties of the places and institutions that surround us, right? These are the opportunities, the obstacles, the exposures, the choices that we encounter throughout our lives from birth to death, but critically across generations. We'll talk about that even in the last few moments here. At this point, there have been hundreds of organizations across the U.S. that have been describing their enthusiasm for this. We now heard about 47 federal agencies, a National Academy's consensus report. There was a commentary published in Health Affairs recently that observed that never before have so many federal agencies and leaders across the U.S. been organizing around the same set of vital conditions. This could be a watershed moment for our ability to move in a direction that, we have always been, let's say, capable of doing, but have never been clear and focused and concerted enough to bring to its full potential. And there's more than just the slogans that are appearing in the graphic. Behind the scenes, there are definitions, very practical definitions for each of these vital conditions. We can begin to see their built-in interdependence and spot those actions that are going to have sort of multi-solving potential, are going to move more than one of these vital conditions through a concerted action. This is not just about funding. It's also the way we communicate. It's the way we measure. It's the way we set policy and the way we shape routine practice. So there are infinite number of ways that we can influence these vital conditions. And there is, as one of our third panel will talk about, new ways of measuring as well. A key feature by design of this is that we're talking about a set of things that all people need pretty much all the time to reach their full potential. We need a thriving natural world. We need basic needs for health and safety, clean air, clean water, nutritious food, routine health care, humane housing, meaningful work and wealth, lifelong learning, reliable transportation. But central to all of those is the we ourselves, right? People have a deep need to feel connected and to contribute. For everybody to feel that to feel love as part of a community, embraced for who they are, valued for what you bring. And the more that we expand that circle of human belonging, we can actually build civic muscle to be able to work across our many differences and create things that none of us could create alone. That's how we both satisfy our need for connection and contribution, which is a vital condition, and it explains a sort of pragmatic capacity to be able to make equitable progress in any other of these areas of work. We need to expand that circle of belonging and build civic muscle to do things that we can't do alone. So that's really how we grow the pool of assets over time. We're not working with a scarcity mindset. We're working with the infinite abundance of what it means to bring everybody, every organization into the work that they can contribute into sort of an intergenerational quest to thrive together. Cornel West very famously talked about justice is what love looks like in public. And I like to think that this framework starts to define what that love would look and feel like if everybody were treated as if their lives and their families and their communities matter. So some of the greatest champions of this work are teaching us that we can counter racism, other forms of inhumanity, with love, and couple that with the civic muscle that's necessary to establish systems that are fair by design. This is not the kind of world that we've inherited, but it actually can be the world that we pass on to future generations. And so much of this work, as you'll hear from our colleagues on the panel today, is about asking, what does it mean to be better ancestors in this work, and reckoning with those legacies of justice and injustice that we've inherited, and doing as much as we can on our watch pass along a movement that is aimed toward thriving together. The last thing I'll say about this framework is that it gets even more clear when we pair the vital conditions with a suite of urgent services. Anybody experiencing adversity might need help, right, in a crisis. It might need acute care for illness or injury. It might be addiction treatment. It might be crime response or environmental cleanup, unemployment and food assistance, homeless services. These are all ways of sort of life-saving, maybe life-altering experiences for people, but none of these urgent services can create the experience of thriving. That has to come through expanding vital conditions. And when we see both sides of this portfolio, we can think about the intergenerational dynamics that are driving well-being and justice in a plural society. Are we relying on urgent services to kind of alleviate adversity and affliction, or are we investing in vital conditions to unlock our full potential for everyone to thrive while still being there and building an infrastructure to deliver urgent services when any of us may need that? So I'm going to stop there with my introduction. There are a lot of resources that are available to us and all of you in this work, but I want to turn to now Ruth Thomas Squance, who has been a fellow traveler and a kindred spirit in this work. I've learned so much from you, Ruth, and maybe just share with the audience what you're seeing about the motivations that are leading you and your colleagues to emphasize this framework and what you're seeing people do with it.
Yeah, sure. Thanks, Bobby. And thank you to the National Forum for the invitation to speak today. My name is Ruth Thomas Squance, and I am co-executive director of Build Healthy Places Network. We're a national center, and we work at the intersection of community development, public health, and healthcare. We focus on transforming the way these sectors work together to create community-centered investments that can advance health and racial equity by addressing these vital conditions for health and well-being. And our goal is really to create inclusive, multi-sector solutions that can then create community environments that are health supporting rather than health opposing. So I think when we set ourselves the goal of achieving health equity, I think it forces us to think about what we mean by health. And we begin to think about it beyond the absence of disease, to think about thriving. The vital conditions for health and well-being can really help support us in this more expansive viewpoint, and also help us look at the levers available to us for making changes. On the next slide, we know that health happens in neighborhoods. And if we look at this next slide, we know that health happens in neighborhoods and that chronic conditions on the next slide, such as cardiovascular disease, are really influenced by people's social and physical environments, as Bobby described. But what we found is that the conditions framework gives us an opportunity to take a systems thinking approach to how the distribution of these factors, the vital condition, how the distribution of them and resources can be skewed away from certain communities along the lines of race, socioeconomics, also geography, and therefore denying opportunities for health and prosperity. And it brings in that concept of spatial justice. So really, just as poor health is caused by those conditions, we know that good health can be facilitated by equitable access to those social and physical environments. And on the next slide, we know that partnerships, are really going to be a key to addressing the drivers of health. So rather than propose a solution, I think for us that hospitals and health departments become experts in creating housing, become experts in creating transportation, as well as everything else that they're already doing. We really think that for our work, what we want to use this framework for is to catalyze those multi-sector actions and create collaborations that go across sectors in the way that you described, Bobby, that can unlock new potential, I think, for addressing these factors and the underlying drivers of the health inequities that we're seeing. So at BHPN, our focus is on deepening impact through upstream investments in community that will improve overall community health and well-being of residents. And just also to add a note that it's equally true, I think, in urban and rural communities that you have that same sort of impact. So one thing that we promote is that as we broaden that landscape of who is in the health ecosystem, the community development sector is a natural partner for health actors that are looking to impact those drivers of health inequities and to redress the harms that we know have been done by patterns of disinvestment in community that was driven by systemic racism. Next slide. So we collaborated with the National Association of Chronic Disease Directors, the NACDD, and Bobby, you were part of that effort with us, where we held a thought leader roundtable and really trying to build the bridge between these two sectors to advance health and racial equity and explore with national leaders from these sectors where we could dig into what their shared values were and create meaningful change in the conditions. And one of the things that was very clear, these are prominent leaders of national networks. Many health practitioners are unfamiliar with the work of community development. And in order to sort of try and bridge that, we created this primer, which is based on the Vital Conditions Framework, as a sort of a starting point to create these conversations around where we know race, health, and place all intersect, and how new partnerships can open up opportunities for helping patients and clients in their communities. So the community development sector is a multi-billion-dollar sector, comes with assets that is investing in persistently underinvested low and middle-income communities through the development and financing of things like affordable housing, schools, grocery stores, health clinics, as well as small business and job training. So immediately you can see the relevance of those to the vital conditions that we've heard about this already today that have been outlined. All those things show up in the vital conditions. And you can access the primer from this link and we'll share them with you. So if we look on the next slide, we can explore what is in the primer just briefly. That it really explains the vital conditions of health and well-being, which you're all experts in now today, introduces the community development sector as this ready-made partner, and then also highlights some of the roles the public health sector, for example, or healthcare can play in multi-sector partnerships. And just to name a few things of this, like can be being a convener of community-based organizations, having a resource of knowledge and data insights that those in the community development investment sector don't have about where the most health impact could be for where they make those investments. We also include a partner finder that's to help you discover partners in your region who else is working in the same communities as you, but in parallel that you may not already know. And it also has some case studies of successful multi-sector partnerships. And on the next slide, I'll just explore a couple of the, some of the themes that come up from that, from the primer in the next slide. And I can share just a snapshot of those. So some of the activities that community development does that's partnered with public health that has focused upstream. One of them could be like establishing community engagement processes to prioritize the needs and solutions of people most affected. And that sort of gets to the centering of belonging and civic muscle that Bobby spoke about. That is, part of the central part of this framework. And it really drives everything that we do as an organization and really should be driving our solutions to be responsive to communities. The community development sector can get involved in developing farmers markets, community gardens or walking paths, increase access to food and healthy lifestyles. And we know that certain environments create higher vulnerabilities to stroke and risk factors such as type 2 diabetes. And these are all strongly related to environmental factors. They also contribute to mitigating the range of physical and mental and chronic health problems that are associated with housing instability just in itself by creating affordable housing, but then layering on by partnering to apply trauma-informed design to that process. So You can explore this primer more in your own time for some resources that can help those that are looking to get started in thinking about community development. Next slide. I can show you some of the several playbooks that we have that are accessible from our websites to support this kind of cross-sector partnership. And so I've really introduced at lightning speed here the new ways in community development and healthcare and public health can work together. And I think if you go to the next slide, you can partner to move upstream and really use the vital conditions. So I think what we know is that business as usual is not getting us to these goals of health equity. And that I think is because it's a multi-sector challenge. It's really going to need us to have those multi-sector solutions. So I hope I can, encourage people to consider these kind of partnerships. And I think this quote I like from that says, if it give me a place to stand and a level long enough, and I will be able to move the world. And I think multi-sector partnerships can be our level long enough to help make those changes we need to see. I'll pause there.
Thank you, Ruth. But what a delightful segue to Shoma. Shoma, I think of you as somebody very firmly grounded in where you are and who you're with, but your ambitions are as big as our capacities to dream. So I'm wondering if you can just share your motivations in this work and what you've been seeing in the years that you've been championing this work.
Thank you so much for inviting me, and it is always a delight to follow Ruth in this work and you. So I'm Dr. Shomava Shaha, President and CEO of Wellbeing and Equity in the World, lead a grassroots to grass stems and grass tops connected network called the Wellbeing in the Nation Network that contributed to the thinking around the vital conditions and helped to move that forward in our work. But the identity that maybe I'll come into this conversation with, Bobby, is as a physician, primary care physician and public health person who practiced in the safety net for over 15 years, seeing person after person who, in family after family, evolve their history and experience of allostatic stress, the stress of continuing in poverty and experiencing marginalization and racism and experiencing a lack of those vital conditions and watching as depths of despair set in and watching as what was possible as you could flip that script, as you could create and build a belonging and civic muscle at the level of a community to change the hope that the community had, driven by youth and seniors coming together to say, what could our community be? At the community health center we were part of, we began imagining, well, what would happen if we saw medical assistants and receptionists as caregivers, as stewards, as you would put it, and actually gave them the tools to improve the health and well-being of our community. And then we measured that using the tools we had at the time, including things like A1C rates and blood pressures, all the things that we would know. We did high-functioning primary care, and we were able to be successful as we did that work. And what that led us to, as we did that work well in healthcare and integrated mental health, did all of the stuff, was that we saw a 40% reduction in all-cause hospitalizations for people with diabetes. And that sounds great, except what we could also see was a fourfold increase in the people developing diabetes and other cardiovascular diseases at the same time. That led me as a doctor to begin to ask, what were we missing? What were we missing in our improvement processes, in our efforts to connect people? And of course, a big part of what we were learning we needed to do already was to address people's social needs, to connect them with food and housing and transportation, one person at a time. But when we stepped back and saw the scope of the problem, the kinds of maps, as Ruth said, that really show that place is a determinant of health, we began realizing that the places, the communities we were in, were missing those vital conditions that you were talking about, Bobby. And that began for me a journey of asking, well, how do we create not just one person at a time solutions that are well organized in a system, but really think what it would take to shift the story in the first place. What would it look like to have a world where no one was marginalized, where everyone belonged, where people could bring all of our collective gifts and assets to solve the challenges of our world together? Well-being and equity in the world exists to build that movement of better ancestors that can create those vital conditions in our communities, in every community, because we believe that those whose voices aren't at the table are the single greatest untapped source of human potential to solve these problems. So what does that look like when you actually put that into practice? Well, I'll share with you that in the context of the pandemic, that meant bringing together people, all calling in the assets of our communities, thinking about public health as not belonging to just a set of people in a health department, but to the wider public as a whole, and especially calling in the assets of our communities themselves. We said, what if everyone belonged and could be a leader of public health? What would they do? And we resourced them to do that. That meant bringing together 10,000 Black artists, activists, Indigenous leadership across the country, farmers and barbers and promotores, and yes, doctors and nurses to all work on this together. We collectively decided to ground this on an approach of thriving, of well-being, and actually asked people what they would need for their well-being and gave them real-time data. Of course, what we saw was that things like economic security and food were of the greatest need, especially in the places where the places were set up without those vital conditions. A really amazing thing emerged, though, as we gave these communities not just permission, but invitation to not be bound by what we needed to get done as a vaccine effort, but instead to be free to imagine what was possible in their communities. And as we introduced tools like the vital conditions and a process of understanding why is it that everybody in our community doesn't have these, what policies and practices are in place that are continuing to marginalize, and what would it take for us to be those better ancestors and to solve these in practical ways, knowing that that wheel of vital conditions actually isn't about separate silos of things, but about things that are connected across the board. What would it look like if we made the solutions bigger to solve the scope, to actually address the scope of a set of connected problems? And that's where the real fun began, because you see some people who could already begin to see that food leads to health and improved health, like we had done at our work in Cambridge Health Alliance. They, of course, were doing policies like food as medicine and healthy opportunity pilots in places like North Carolina. But the problem was that they needed to figure out where to get the food from that would create the best health. And they hadn't yet thought about the idea that if they were, instead of just screening people for food insecurity and providing people with prescriptions for food, if they could see that the very people that they were providing those prescriptions from included farmers and faith leaders from their communities who were trying to help people be healthy, but didn't have the generational wealth to be able to assure that something could change. In fact, what really happened was that the farmers in North Carolina, a set of Black, Indigenous, and Latinx farmers came together. And they asked us, well, what would it look like to change this picture? And because they weren't limited in their imagination, and we could bring in people from across sectors, people who were leading food purchasing in the hospitals of some of our largest healthcare systems, policy leaders that were looking at economics and wealth, USDA leaders, as we began to see that wheel, not as a wheel of problems, but as a wheel of possibility, we began calling in all the people that had a piece. And suddenly someone said, well, wait a minute, if all of the farmers were in cooperatives, bringing together a set of belonging and civic muscle, and we could invest in that, maybe we could purchase from that. And that became a strategy for hospital systems and schools and many others. It turned out that there were farm bill dollars that were not being taken advantage of because there wasn't the fiscal and administrative infrastructure. Someone else said, well, maybe we can build that. And then there was a Medicaid waiver in place to begin to think about how to make sure everybody got food. But the state had never imagined purchasing that food or creating the conditions for that food to be purchased from generational farmers who had been disadvantaged. And so by thinking, how can we do three things at once rather than just one thing? What could be a multi-solver in this region? They began imagining, well, what if we, yes, let's screen for food insecurity. Yes, let's prescribe, but actually let's purchase. Let's go all the way to creating economic security for the same people who are in our clinics, maybe as patients with poor heart disease, but instead actually are community change agents who can be who are farmers and growers. If we can imagine them not as poor and weak and hungry, but instead as strong and capable with assets and gifts to offer us, we can actually see that we can do so much more together in creating economic stability while they grow the food that in fact in Eastern North Carolina fed a whole region through the pandemic. What they ended up doing to go beyond that was, as the universities came in, they began training people in regenerative agriculture, and that they began imagining what that could do for the climate. And as they understood what had happened to the land and reflected on their legacies of sharecroppers who never got their share and of indigenous farmers who had lost their land, they began imagining an entire process where, as they grew generational wealth, they could begin to actually have the land restored and stabilized for the people who had been generational farmers on the one hand, and who had incredible expertise in stewardship of the land on the other. And that, to imagine that entire sequence of events could happen in 6 weeks, that entire sequence of what I describe as radical imagination of what it would look like if we believed that we were in fact powerful enough to build the legacies that for the next 7 generations, that we can understand how we got here, that we can choose to be better ancestors. And then this little tiny wheel that's so colorful, but has so wisely the words belonging at civic muscle at the center, that could serve as a way to begin to say, let's bring in a movement of better ancestors who will bring our pieces together to change those legacies for the long term.
Thank you so much, Shoma, for bringing us along in your learning journey around this. It's thrilling to imagine that a lot of this came just by asking the question, what are we missing? You were working at the top of your game in many ways with the Cambridge Health Alliance, and then asking what more? And the discovery is so much more. Bern, maybe you can pick up on where your thinking around this work is leading you. Where are you seeing some of the greatest opportunities for advancing the goals of cardiovascular health, through the lens of these vital conditions?
Thanks, Bobby. Given my passion for the integration of mental health to improve thriving health and well-being, I'm going to focus on how we can use vital conditions to enhance mental health and promote cardiovascular health. As incoming co-chair of the National Forum for Heart Disease and Stroke Prevention, I am absolutely delighted to share we are deeply committed to the vital conditions framework. There is currently a mental health pandemic in the United States, with health disparities being very prevalent. We all know mental health can either positively or negatively affect cardiovascular health. But there's a growing body of quality evidence that supports stress, anxiety, and depression affect cardiovascular health. And mental health resiliency is a protective factor for both mental and physical health. One of the domains of vital conditions, as Bobby pointed out earlier, is basic needs for health and safety as a vital condition. And that includes freedom from trauma, violence, and addiction, nutritious food, safe water, physical and mental health, routine physical activity, fresh air, sexuality and reproductive health, and sufficient sleep. A paradigm shift is greatly needed in our country right now. We are a sick care, crisis care, healthcare system. We spend more money on healthcare than any Western world country, but our population health outcomes are poor. So we so need this vital condition framework because health and well-being goes so far beyond just health care. The other thing we desperately need in this country is to reduce the big time gap between research and practice in real world settings. We used to joke back in 2000 when research was done that it takes 17 years to translate findings from research into practice to improve care and outcomes. Another study came out in 2021 that actually showed we reduced the time gap to 15 years in 2 decades. So at that pace, it's only going to take us 150 more years to translate what we know works through high quality research into clinical care, into our communities. The gap between what we know and what we do is lethal. We also need to de-implement what is not based on best evidence. So by shifting resources to the domains in vital conditions, I feel confident we can really move the needle and improve our population health outcomes. On this slide, I illustrated how vital conditions and policy strategies might improve, should improve mental health. In terms of the thriving natural world, we can increase green spaces because we know green spaces that are safe for people to walk in, connect with others, can definitely improve mental health. Basic needs for health and safety. We need to invest in infrastructure to ensure that all people who need it will have access to mental health care, because less than half of people with mental health conditions receive treatment. We need to strengthen school curricula to include evidence-based mental health resiliency building. We have several evidence-based programs that are shown to improve mental health. We teach our children, our teens, all these other subjects. But what is more important than giving them evidence-based cognitive behavioral skills, mindfulness skills, other life skills that will benefit them and protect them the rest of their lives? We also need to ensure all health systems that deliver care to all people, including people of color, implement the highest quality of evidence-based care. In terms of belonging and civic muscle, we need to provide reimbursement for community health workers. We need to ensure group a lot of quality evidence behind it is provided for those who desire it. And in terms of lifelong learning, we need to increase access to addiction treatment and invest in high quality childcare, including the implementation of evidence-based parenting programs. An example in Columbus that was founded by one of my good colleagues, Dr. Pat Gabby, is a program to reduce maternal mortality and adverse outcomes in pregnant women called Moms to Be. It is now in 8 communities in Columbus, Ohio, where pregnant women get together for education and social support. It has shown great outcomes. Now we need to scale that program throughout our entire state and the country. Lastly, I want to provide an example of a signature initiative that was launched by our national forum about 10 years ago. Move with the Mayor has been incredibly successful in building healthy, active communities. And because the forum has recognized how important mental health is in creating thriving, resilient people and improve their overall health, including cardiovascular health, we sponsored another challenge for mayors called Mental Health and Physical Activity Challenge. We had 44 cities in 22 states participate in this challenge. This movement is creating healthier, connected communities, again, using this vital conditions framework. Lastly, I just want to ask us all today, in the next 5 years, what can we do if we know we absolutely cannot fail with great partnerships and an investment in vital conditions?
Thank you so much, Bern, for reminding us. You've given us some very important keywords here, that there is no shortage of things that we can do, right? There's a mounting evidence base. There's a kind of engine that produces more and more of the what's we could be able to do. But the why and the who and the how is part of that paradigm shift. You've given us words like movement, right? This is not just a single program or project or policy that we need to enact. We need to be relentless about establishing the conditions that are needed, and for everyone to play a role in that. I've heard that in all of your stories, this connection around sort of re-centering on who is doing this work and how we are doing it. So that's, maybe I'll invite us into a discussion about what you're hearing in each other's stories, starting with this idea of the players involved in this work. Each of you have told stories about getting people into a different role that starts to ignite their contributions. We heard it from you, Ruth, about how community development is a ready-made industry that a lot of people in the health, sort of professions do not know what is happening. And Shoma, you talked about the powers of farmers, thinking about what they could do to feed a whole region, but then what that region can do to assure, the healthy environment that is needed to grow healthy food, and what that could mean for an economy. And, Bern, you're talking about the role of mental health, for example. There's no slice in the portfolio pie chart for mental health. You need all of these vital conditions, all of these urgent services to tell the story of, are we establishing a society that's built for people to be mentally healthy? And, heart and stroke brain health is in some ways a consequence of stacking the deck in favor of people's well-being from the start. So maybe let's just hear what's on your minds after having heard these other colleagues describe the shifting roles of the players who are doing this work. Could go in any order, whoever wants to go first.
We have heard so much negative about the effects of the pandemic and their ongoing nature. What I think we need to do more of, which we have done today, is give examples of the positive outcomes of the work that is being done to create thriving communities and people. I think that's what's missing right now in the media, is just more stories like this to inspire people, to give them more innovative ideas and programs that are based on evidence that work.
Yeah. And Ruth, your primer featured some of those cases. Just can you describe a little bit about what it took to find and spotlight those examples that gave you all hope?
Sure. I think one of the things that we saw was that a lot of the collaboration with public health or healthcare was very downstream. So what you would tend to see would be more direct services. But again, with an asset framing, what we think is that serves as a starting point of the relationship. So you already are working with someone on a programmatic level. It gives you an opportunity to imagine where you could go with that. Where could we go together to move upstream? And it made me think of something that Shoma had said, that question of what are we missing? And I think that having that to build into our practice, that self-awareness to ask, and also then that other awareness to listen, to actually hear from the communities what we are missing, and to help sort of fire that imagination of new ways we can work together.
Yeah, Ruth, I'll build on that. In our work, we say that equity is a path to abundance, that this work happens in the context not of each of us being brilliant, but in the context of each of us being trustworthy, of seeing ourselves as connected to one another, as working with whatever pieces of the puzzle we have, not from a place of deficit, from a place of abundance. And I think that there's something, as each of you were talking, the word hope kept coming up for me. What does it look like for us to show up is as hope bringers for each other, as people who value our solidarity of showing up for what each other needs, not just what we need? What does it look like to have a social contract where we know that collectively we each have what we need? And, what you may need and what I might need are different. We may not have them exactly to give each other. But if we build a nation, if we build communities where we can give that to each other, knowing that at some point it'll pass back around to us, maybe we have to stop, not spend so much energy protecting the little tiny slice we have, and instead be able to see a bigger picture, a bigger possibility, a bigger set of solutions together. And, across the country, in places like Arise, what we saw were people for example, of different races, of different ages, at vastly different parts of the political spectrum, be able to get beyond the rhetoric and start asking, what would it take for us to have communities where people weren't suffering, where people were thriving? What would it take for us to bring our assets together to do that? And not what can't we do, but what could we do given what we have today to be able to build communities, and the kinds of solutions we were able to all ask when we went from that, what the problem is, to what the solution is. We're just brilliant and creative and built the possibility of our shared stewardship.
Yeah, I love that example because there's, we've tried for decades to organize around things that we want to prevent, things that we want to stop. We're really just beginning to learn, or I would maybe say relearn, some of the lessons about what can happen when we organize around the things we most want to create. It brings to mind an example of when the Surgeon General, Jerome Adams, who I gather is on the board of the National Forum, right? Every Surgeon General throughout history has picked their issue. And for Jerome Adams, it was the interface between community health and economic prosperity. And there's no accident when you're looking at businesses, not only for, the kind of practices and products that might harm people, but how can businesses be investors and engines of creating the communities we most value? They ended up organizing that Surgeon General's report around vital conditions as well. So it ended up being this transpartisan, trans-sector framework that emphasized the investments that we can make in the things we truly value. And I'm hearing that kind of investment priority theme in your work as well. Ruth, to some degree, that's what community development as an industry.
For sure. Right. I mean, exactly that. If we're talking about looking at connecting systems, and I'm thinking, responding to what Shoma said, Antipon said, what do we have to do systemically to change the way we work in our practices and connect the things that we are trying to do? I think, we can look and understand where something like, I'm seeing the connection already from what has been described about the mental health crisis, the impacts of that on even, chronic disease sort of prevalence. And we know that, for example, the community development sector that is investing in zip code improvement, if you want to say, for a better word, it reduces some of the most common stress factors. It's around affordable housing, reduces financial stress, the stability of housing as that hub for connection to services in terms of reducing unhoused and unsafe neighborhoods. So we can begin to sort of see where our goals and aims in one sector can really be aided and abetted by others. I'm thinking, again, stable housing, the impact on ACEs, that life course element that you had mentioned as already, sort of, Bobby. So I think that it's sort of interrogating our systems as to what are we missing, where can we make those connections, and collectively change the way and where people are experiencing health, which we know is where they live, work, and play.
Maybe we'll end with just a quick round of what you would wish for, what you might be looking for in the decade ahead, right? We've got momentum around this, calling for a paradigm shift, examples. When we go to know where to look for them, we can find them in plenty. So what do you wish could happen in the decade ahead? And how could the constituency that cares about heart disease and stroke end up being on the vanguard of some of the most important changes that we may be poised to make? So your parting wish for the network of colleagues who are listening here.
I wish that we could reduce that research practice time gap to 0 years. So when we know something works and there's quality evidence behind it, like we know about many of these vital conditions, we invest in it, we resource it, and we make it happen.
I think I would say that, while we're promoting this thesis, this model of cross-sector collaboration, we also have to acknowledge that takes time and energy, and people are already busy doing their own job. I would love to sort of see the sort of also that investment that Bern referred to in who is the cross-sector partner, who is the cross-sector department of your industry or sector that makes that's whose role is to curate those kind of coalitions, to curate those kind of connections, and help keep this on everyone's as agenda in their sites as to the way that they do work, who will be there to always ask the question, what are we missing, to sort of actually resource that part of the work.
And my hope is that we would develop practices where we were unafraid to look at the past to understand how we got here, unafraid to share what we have, so that those who have been marginalized, whose solutions and assets and gifts can't easily come to the table because they don't have what they need to offer them, and that we would be unafraid. That's
so lovely. And it's often said, one of my great teachers in this work says that we grow in the directions of the questions we ask. And I wish that we keep creating spaces to ask these kinds of questions, to stay on the learning journey that will propel us to the next adjacent action, the next adjacent partner. And that's how we grow a rising movement around the values, the things that we most want to create in the world. We will overcome partisan differences and sector differences. We will negotiate those things, but we shouldn't shrink from our values of shared humanity and that quest to thrive together. So thank you all for your time. Thanks to everybody who's been part of this session. We've got several more panels to come, which will provide even more of those examples of who's doing what, where, and how is it getting measured. So stick with us. The National Forum is providing an amazing space to look at the state of the art in this work. So thank you all.
Wow. Doctors Milstein, Thomas Squance, Saha, Melnick, thanks for a truly rich discussion. We're privileged to provide the space that you just referred to, Bobby, for what I think is a great discussion based on some of the comments I'm seeing from folks. It's one that is highly valued. We'll now open the floor for questions, and please feel free to ask our panelists anything that you'd like to explore further via the Q&A button at the bottom of the screen. I'll note that Bern Melnick she was unable to stick around for Q&A. She's also chairing a summit today on clinician well-being, so doing double duty, but we're very fortunate to have Bobby, Ruth, and Shoma still with us. The floor is open and they're ready to answer questions about using the vital conditions framework to strengthen social determinants of health and advance cardiovascular health for all. Before we begin with Q&A, I want to share my goal for this meeting with you. And that's for you to get at least one idea, one strategy or tactic that you can implement next week to enhance your organization's impact on cardiovascular health and well-being. So as you pose questions, you might think, I heard this idea. What else do I need to know to help me share it with my colleagues and take action? We hear many of our colleagues and allies in the quest for health equity say, we've just gotten social determinants of health into the mainstream, at least into the policy, health policy mainstream. And that was a heavy lift. So please, can we not displace social determinants with a new rubric? Now, Bobby addressed this concern a bit in his introduction, but I think it's such a crucial point, one that we hear with great passion. So it bears a little more conversation. And I'd love to hear how each of you view the interplay between social determinants and vital conditions. Ruth, you want to lead us off, and then Shoma?
Sure. I think for us, the case I would make for the vital conditions is that they're very accessible. And the fact that it really does open up the concept of the social determinants for those who are outside of the health sector, and to see how they can engage, where they can put their shoulder to the wheel, and where they can work with us to help create environments that support health.
I'll build on that. If you think about it, social determinants of health was language that we have learned to internalize as a sector to shift our mindsets. It was about us reorienting. But as part of that reorienting, if we do this work well, we come in relationship with communities, with patients experiencing inequities who have who have a broader frame to their lives. They're not thinking, what are the social determinants of my health? What communities told us is they really need in their context, if we're to join them in an equitable journey, really their mindset is about what are the conditions we all need to thrive. And the vital conditions, which is why they're grounded in things like belonging and civic muscle. They're really about us having gone on our journey as we've embraced the social determinants, understanding that to change those social determinants, we need to come together as part in community. And in community, we need to build a shared vision for what it looks like for all of us to have what we need to thrive. And that's really what the vital conditions invites us to, in language that's plain and simple, and most importantly, chosen by communities.
Yeah, that's exactly
Yeah,
my answer.
Bobby, before you answer here, let me just say Wendy Bailey really put a fine point on this and asked, how are vital conditions, are they the same or different from social determinants? I think Ruth and Shoma have addressed that, but if you can put a similarly fine point on that answer, that would be great.
I love the question, and I'll just pick up the spirit of what Ruth and Shoma have already said, which is that the genesis of this vital conditions framework comes from some of the champions of social determinants discovering what is it going to take to bring more and more people into this work. And one mark of the growing not only mandate but momentum around this is the idea that we have to turn the chapter and be more specific about what it is we're going to do, right? So getting across the idea that health is more than healthcare was an important historical accomplishment. Identifying classes of, drivers that might matter is useful, but this work is now matured to the point where we need to be really specific about what is it we want to create, and the ambiguity about social determinants, but now like which ones and where and with whom and how. It's just too confusing for so many people who are ready to roll up their sleeves and do the work. And so that's the mark of what this sort of, let's say, emerging dialogue in the field is demonstrating, that there are more people ready to act in spaces that they historically haven't. And we can be comfortable with that, because there's not just one vocabulary for this field. It depends on who you're engaging with and how. If somebody, is thinking in a very narrow biomedical frame, they may need to understand the whole idea of social determinants. But if you're dealing with people who've been at that work for a long time, maybe their whole careers, now we need to really have a conversation about specific vital conditions. And so to Wendy's question, anybody who understands either framework can crosswalk the two. I can code switch with different colleagues. It's not important that we have dogma about language. It's important that we have frameworks that help us do the work that we're poised to do together. And, too many people who had been, sort of carrying the flag of social determinants were saying this is alienating some of our best allies who aren't really necessarily motivated to organize around health, but they are motivated to organize around thriving, or, the idea that we together could create, a deeper sense of belonging. We can use our civic muscle to do more than one thing at a time. And so this framework is sort of easier for concerted action, because it doesn't put health at the center of the storyline in ways that, have been limiting for this field.
Thank you. Thanks to all three of you.
Yeah, it sounds like
so we have
to
some.
add more to that.
I was just going to say, I think the other way to think about it beyond language is the social determinants as a what, whereas the vital conditions are a how. They're really are beyond just the words on that wheel, a method of saying, how might we look to understand why everyone doesn't have what they need to thrive and what it would take to get there, which begins with that understanding that we need to be in relationship, that connection and belonging, and that we need to then exercise our shared power and privilege to change the system. And we need to understand that all these things are connected. They're not separate boxes, but in fact, housing and health and our mental health and our job security, our ability and whether we have it, are where we fall in terms of economic or racial disadvantage and residential segregation. All of these things are actually connected. They lead to poor health outcomes and education outcomes and life outcomes. So there's just a way in which the wheel and then the idea of what it means for us all to thrive and how can we really know we are and what it means to create practical change. It's really that set of hows that I think is the biggest differentiator. That's where I invite you all to go beneath just the words that are on the outside of the wheel, which look exactly the same, to know it's really about how we get there.
Shoma,
I love
audience members are giving your answer a lot of love. So thank you, Ruth. I'm going to ask that we put a pin on that or in that, because we have several more questions. So let's try to keep our answers brief, and I'm going to direct this question first, the next question first to you, Ruth. It's asked by Warren Jones, and he says, how do you recommend addressing what I would call weaponization of social determinants and health equity in communities? Many communities may be shortchanged resources because of those tactics. And how do we avoid the same for vital conditions?
That's a really great question. And that's just something that we've definitely seen and been responding to in our work nationally. And I think this speaks to the comments that we've had earlier about not focusing so much on the words, but the actions that are associated with those words. And I think what we're sort of looking at, what we're talking about, is value-based conversations where you're really reaching mutual discussion by focusing on the underlying values that you are trying to achieve, sort of a collective why that can be the stewardship of why you want to create thriving for everyone in your community. And then the implementation of that is through the social terms of health. So while the words health equity may come in and out, I think the values that underline them are not as divisive as the words that have been weaponized. So I think that we can find mutual bridging between that, from things like humane housing as Bobby can speak to, is a specifically chosen word. Humane housing is not just any housing; it's a value inherent in that does underpin health equity. But whether you're saying health equity or not.
Yeah, thank you, Ruth. Madeleine Ogani from Emory University says she would argue that health is not a word that alienates, that everyone wants good health. Does that resonate with you, Shoma?
It's certainly true that everybody wants good health. And I would say that our in our country, people associate health as physical health. And they actually don't think a lot about how the fact that we actually have tons of data now. And my first master's is a fold higher difference potentially based on where you grow up, and decades of life expectancy difference based on whether your community has a vital conditions. I wouldn't have guessed it.
Yeah, that is such a key point. And it's one that we had a panel at last year's meeting that Bobby Jerome Adams led. And one of the key takeaways from that panel was that even in really conservative states in America's heartland, they were able, Indiana, my home state, was the example that was given. And they found, these advocates for health equity and public health found that they were able to get everybody on board, widespread support by focusing on what Shoma just alluded to, those differences in life expectancy, even within communities and certainly between communities, and by making the discussion local about people's neighborhoods and their quality of life. So there's a discussion last year, you're bringing continuity to that line of thought and those real experiences. Bobby, I think of you as, when I think of vital conditions, I don't know if this is fair or not, but I think of you as sort of like the Ace Hardware store owner. If I'm looking for a tool related to vital conditions, I'm coming to your store first. So we've had a couple of questions from people. Are there tools to help us use the vital conditions in our setting? I know they're out there. Can you all give just a couple of quick suggestions about where people can find them? And by the way, we will have links on the this meeting webpage, so you'll be able to find some of them there. But I know there are others out there.
Yeah, it's a great question. The short answer is yes, there are tools, and there are not enough of them. So we need to build more of them. We need to make it easier to exchange those tools. Shoma, Ruth, myself, and others are involved in building these tools or curating them, so that what we make it easier for people who are now beginning to orient their work on actually producing vital conditions, have a suite of resources that fit them and their role, and like what their exact circumstances are. There's a lot of variety there, and as a field, we definitely need to build a light enough infrastructure where a new generation of tools can get to the people who can best use them and then iterate and evolve. I don't know anybody in this work that hasn't created tools that they think are finished and final. They're all works in progress, and so the more that we use them, the more that we talk with each other, not about, yes, we need to value vital conditions, but which tools work for whom in which circumstances, and how are we learning about the practice of doing this. That's what's next, right? I mean, and there are networks, the Build Healthy Places Network, the WIN Network. We have a sprawling network of rethinkers. There are lots of organizations at this point. The WIN Network itself is made up of thousands of members who've joined and said, yeah, this is a big part of our work. And it is a kind of learning platform for the field. If it didn't exist, we'd be talking about how do you create it, and it's a movement of movements, right? So there, in some ways, we have a lot of tools. It's hard to find them and sort through them, and that's what's next. We need co-investors to help build, user-friendly libraries of these. The link, last thing I'll say is the link I put in there is to the Community Commons, which is an amazing asset to the field for all kinds of work, a free repository of resources that we all hold in common. And they started organizing their database around vital conditions back in 2018. And there's hundreds of thousands of users of the Commons now. We just need to bring that to the tens of thousands, the millions of us who are, able to do this work.
Yeah, thank you. And we've run out of time for Q&A, but I do want to get one more question in. So let's just take Bobby's answer to the previous question, go with that. I do want to point out to folks, if you haven't been looking at the chat, check it out, because our panelists, in addition to responding in real time to your questions, have been entering links and other information and observations into the chat, as well as a lot of really rich comments from other meeting participants. So a lot of great information and observations in the chat. So I commend your attention there. Shoma and Ruth, the final question is from Kayla Flores Tyndall, who says, I completely understand why the vital conditions in this conversation is related to preventing heart attacks and strokes, but I think many people will find it hard to understand the direct connection. How do you convince people that focusing on vital conditions actually can have impact on downstream outcomes like heart attacks and strokes? And as I said, we're past the time for the next panel, so if you can keep your answers brief, that'll be great.
I can jump into the quick example. So I often use stories and examples. And one is in a project we're working on in North Carolina. What we're looking at is in a county that has some of the worst cardiovascular outcomes and diabetes outcomes in the entire state, largely rural, small Black community. It turns out it's farmers and the communities associated with them who are growing up in historically marginalized communities, former slaves turned sharecroppers who never got their share, who have the worst outcomes. And those are generational, historic, and related to the conditions they have. When we adopt the vital conditions framework, we can actually understand that if we can shift the way we not just prescribe food as medicine to address heart disease, but actually partner with and fund and resource farmers, Black, Indigenous, Latinx farmers, to be able to build generational wealth, to be able to connect faith communities that are Black churches and women's groups and others, to be sewing circles, to begin to connect them in ways that helps make health and well-being part of what people do. And we resource them to be able to come together to bring the public into the health of the public. Our assets to change cardiovascular outcomes is much higher than if I was in one of the community health centers that's part of that initiative as a primary care doctor, just trying to convince someone in my 10 to 15 minute visit how to eat healthier.
Yeah.
It's really about making the conditions of the community a place where people can afford, buy, and sell and have healthy food be a norm rather than a special thing.
Excellent. Excellent. Ruth, you get the last word here.
Get the last word. I think that is the power of the vital conditions, is that people can really see and understand the set of things that support the work that the health system is trying to achieve in terms of prevention, in terms of treatment, that we know that I think that there's a lot of movement. I think some people may find it difficult, but I think there's been a lot of growth. And from what Bobby alluded to, there's been a lot of movement, people understanding how health is experienced. So I think that the vital conditions is a great framework or tool to get us over that last step and to recruit our partners and our collaborators in achieving healthy communities to support the work we want to do in the health system.
Wow. Terrific. Gosh, I think we have more questions, I think this discussion could go on for another, for a while, and it would be very enlightening. But we do have another panel. We need to move forward. They're waiting in the wings. This has been terrific. So Bobby, Shoma, Ruth, thank you so much for illuminating the vital conditions for health and well-being and how they connect to cardiovascular health and well-being and to health equity, and really look forward to seeing the follow-ups. Shoma, love the stories. That's a great teaching tool. Thank you all so much. Really appreciative.
Well, thank you, John, and welcome to the next panel, and really a day-long spotlight on understanding the frontiers of working with vital conditions. And today's panel, we're going to focus on 3 pioneering place-based partnerships that are organizing around vital conditions, led by 3 of my favorite colleagues who've taught me so much about this work. We're joined with Samantha Shack, Executive Director of the Leonard Parker Poole Institute for Health in Allentown, Pennsylvania. Rosalinda Natividad, who's the founder and CEO of Insight Networks, that talked to us about work in the Doña Ana County, New Mexico, on the border, U.S.-Mexico border. And then Liz Baxter, CEO of North Sound ACH, up there in the northwestern tip of the U.S. on the Canadian border. So we're covering a lot of geography, but more importantly, we're covering a lot of the frontiers of what it means to really focus on establishing vital conditions with community, people, and place in the foreground, with a special focus on equity and racial justice. Our colleagues will also talk about who they're doing this work with and how they're working across differences to share power, to honor everybody's expertise in doing things that none of us can do alone. And we'll talk about how do we channel resources toward those that have the most to gain. There's no shortage of opportunities to make great strides in this work, but how do we do that leaving nobody out and being able to stand in solidarity with those for whom the world has never been built for them to thrive? So we'll start in Allentown, Pennsylvania with Sam. Tell us a little bit about how you came to, what was going on with you and your work and your colleagues when you started to focus on vital conditions, and now what does that mean for you in your efforts to establish health and well-being for an entire communities?
Sure. Thank you, Bobby. Happy to be here today. The Poole Institute for Health is a subsidiary of Lehigh Valley Health Network. And as Bobby shared, we're in Allentown, Pennsylvania. And when we started in 2021, our role is really to invest with communities. So thinking about a very deep place-based approach to investing in vital conditions, and also to invest in leaders as we increase our collective capacity to think about new and innovative ways to create conditions for thriving, and therefore, hopefully, improve health over time. So when we started, we really wanted to focus on how do we get upstream? How do we make sure that we are investing and using our resources in ways that creates more opportunity for people to thrive over time? And thanks to our colleagues at the Ripple Foundation and others, really have embraced the vital conditions framework as our way of thinking about that, recognizing that social determinants of health have become a term that is used interchangeably for both those things that are meeting urgent needs and those things that are longer term approaches and strategies over time. And the vital conditions framework provided us with new language and a new way to frame that, to think about what is the totality of the ways that we're investing in our communities and making sure that we're balancing both the social needs and vital conditions pieces. So Allentown, Pennsylvania is about an hour and a half outside of Philadelphia and about an hour and a half from New York City. We are an urban core of a 2-county area within Pennsylvania, and we have about 125,000 residents here in Allentown. And over the last decade, we've really seen a reinvestment in our downtown in Allentown, and have a lot of new business and economic development that has happened. And over that time, there's been a lot of conversations about what happens in the neighborhoods surrounding that downtown area. How are we making sure that they're invested in as equally as we have been in our downtown? Those neighborhoods tend to be those that have been disinvested over the years. And so really thinking about how do we make sure that the economic benefits that are coming into the city are reaching to all the different neighborhoods that are in our city. And so when the Pool Institute for Health began, we wanted to take a place-based approach. And for us, that means how do we think about a neighborhood and where the vital conditions are intersecting in one place? We know that people spend most of their time in their neighborhood and access most of their resources there. So can we decrease our geographic footprint and think about how housing and education and food access and civic belonging, sense of belonging and civic muscle all intersect in one place. And in doing so, realize that that will lead to systemic changes, sustainable changes over time. And so our first neighborhood that we are partnering with in Allentown, I think there's two things I'd want to highlight about that. One, a number of years ago, we started what we call the Pool Fellowship for Health, which is a 6 to 9 month training program for nonprofit and government leaders around what are the skills needed to work in cross-sector collaboration. At the end of the day, what underlies all of this is that we all need to contribute towards the solutions to address those really complex problems we know our communities are facing. And we don't often have time or space to think about the skills that are needed to work in collaboration. Collaboration is hard. It's not the easy solution, but it is the more impactful one over time, we believe. And so how do we prepare our leaders of the future with the skills they need to not only think about their organization and their outcomes that they need to achieve, but how they contribute to something greater, something bigger, and how they might look for opportunities where coming together with other cross-sector partners could lead to different or new solutions that wouldn't be possible if they were working independently. So that has become a really core piece, that fellowship. We've grown over 100 leaders over the last 10 years. And that enables different kind of conversations than we were able to have before. There's new language for us to build on, a new sense of trust. Trust and relationship building is core to that, and making sure that there's a starting place for us to think about that cross-sector partnership, and being able to bring that piece together within the neighborhood that we're working has been really impactful. And the second thing I would want to highlight is the sense of belonging and civic muscle. That is the sort of core of the vital conditions framework. And I think the one that has been least invested in over time, and the one that without which we cannot do any of the other pieces. And so we've spent a lot of time building up our neighborhood infrastructure, thinking about the community as a system in the same way that the healthcare system or the education system or the housing system exists. And often we don't think about it that way. We think about individual people living within the community as opposed to, what is that system that they are working within? How do they connect with one another? And then be able to bring forward their voice, their desires for their community and their built environment. And so we are really working with our community organizing partners, along with many others, to have a neighborhood association, to think about how neighbors and residents are connected to one another, to get to know the individuals that are living within the neighborhoods that we work, so that when the healthcare system or any other system needs to do that outreach, that engagement, we have a container in which that can happen, and we're in more of an ongoing relationship as opposed to being more transactional. And all of that is sort of situated within a larger healthcare system that has a 7-county footprint and growing. And we have to also think about how do we do that not just in one neighborhood, but across our entire network. And the Vital Conditions Framework and Wellbeing portfolio has become a way for us to unify the different levels of intervention and partnerships that we have across the network. We are cataloging all of our community health related efforts using that Vital Conditions framework and well-being portfolio to make sure that we can think about what are the types of urgent services and partnerships around social needs that we have in each of our different communities that meet that community's need. But also, what are those investments in vital conditions? What are those longer term prevention strategies that we are thinking about? And how do we make sure those are balanced, or where there are gaps that we can identify and move forward together with that? So I think it's a really helpful framework for walking it back to how does this tie to health and healthcare? And how do we think about the wide array of services and partnerships and deep community work that we need to have, but recognizing that it's not a one size fits all, that we'll have to customize that to each of the communities that we're in. So with that, I will stop there and happy to answer any questions as we go on.
Well, thank you so much. And what I'm struck by is how many questions you asked in that summary, all the questions you're asking yourselves, all the things that are leading you to form different kinds of relationships. Your focus on health and well-being hasn't diverted, but but the questions and the scope of who you're going to find those answers is changing so dramatically. So thank you. That's a really thrilling way to tell the story. Rosie, I've heard you ask some very poignant questions and ones that I'm still learning into. So please tell us your story.
Thank you so much, Bobby. And it was such a pleasure to be here today. Rosie Natividad. I'm founder and CEO of Insight Network. Insight is a community company. We are headquartered here in what's called the Borderplex, so New Mexico, Texas, and Mexico. And our mission is to ensure that all diverse communities have economic mobility. And we do that through community-centered strategic planning, grants management, and grant writing. And so I wanted to share with those that are watching today, I founded the company understanding as a third-generation Mexican American that everyone's journey to health, wealth creation, well-being, it's not always equitable. And I wanted to utilize coordinated talents across the nation to create better journeys for those communities nationally and those struggling unnecessarily. And so when I learned about the vital conditions, it was through a partnership with We in the World. They were working through health equity initiatives across the state of Illinois. And I was so inspired by the work done that I included it into the DNA of our company. So vital conditions is actually a mainstay of what we do. You're going to see more of that work come in 2025. It is a wonderful organizing framework, especially with our partners that we work with that are mostly in government. And so when it comes to how we utilize the vital conditions for health and well-being, I wanted to tell a story about my backyard. So where I come from here in Doña Ana County, New Mexico, El Paso, Texas, Ciudad Juarez, the borderland area. Doña Ana County is beautiful. If you haven't had the opportunity to come during the fall season, enjoy some hatch chili, some Stamen pecans, some of these national brands that you may see on the shelves, but you haven't had the opportunity to meet the local farmers, ranchers that grow it, we encourage you to come and see our community. It is the second largest in the state of New Mexico, bordering around 220,000 residents, and it's vast. 3,800 square miles of varying type of topography, from our beautiful Organ Mountains, again, to the rich northern areas of agricultural, to more industrial-based feel to the border as we grow our borderplex and our port of entry. And so there's so much to be seen. And at the same time, Bobby had shared, sometimes a world isn't always built for us to thrive. And so while I absolutely love our community, we are working to strategically plan and build a vision for that county where all are thriving, all are aging well, all are feeling that they belong and are civically engaged. And so similar to other communities around the nation, there was a significant community degradation from the racial legacy of interstate highway construction seen through urban planning in the 1950s. There was also a use of exploitation of certain type of development law for unincorporated settlements that was entirely built for Mexican immigrants as they were looking to make their way and achieve the American dream in the United States, creating colonias. And so there are 37 colonias in Doña Ana County. That's 25% of the state's colonias. So we do have a significant amount of people living in poverty with unpaved roads, lack of electricity, water systems, wastewater treatments, and decent housing. And so how can Doña Ana County community, the elected officials, our community residents, our state, how can they move past these systems that they've inherited and policies that were inadvertently or advertently racist? How do we move past that and build beyond and think of a world where we are all thriving? So here enter the vital conditions. And so with the vital conditions, we did integrate that into the strategic planning process. We are creating what's called vital condition teams. And we are modeling that after the federal plan for equitable long-term recovery and resilience that we saw put together through the Rethink Health Initiative and partners. And we're creating multi-solving environments where departments are working with community residents and gaining their feedback. Another initiative that we did was actually kind of turn how strategic planning is done around. And we spent 6 months building out what we call the minimum viable product. We wanted residents to actually have something in their hands to respond to, rather than take them through a year-long journey or more and not know how their feedback was going to actually be incorporated into the strategic plan. And so we're very thankful to have different frameworks that are being utilized, such as the Spectrum of Community Engagement to Ownership framework by Rosa Gonzalez, so we can actually measure how individuals are feeling as far as being part of the strategic planning process and implementation efforts, and if they see themselves as part of the fabric of the county government. And so our partners, really, we started first inward with the departments, so that they themselves are breaking down any silos, become multi-solving teams themselves, and then began work with our varying jurisdictions around us. So we become one county, as the vision indicates, and then moving out to our regional and state level partners. And so I'm excited. Our new county manager, Scott Andrews, who has started in Doña Ana just this month, is going to be facilitating a process for a state of the county address, where we'll be talking about the outcomes of the vital conditions framework, the family of measures, and presenting side by side with community residents. And so if you have some time in March, we again encourage you not just to come down for some hatch chili, but join us at this state of the county address and be a part of our efforts to change initiatives and work to have everyone thrive.
Thank you, Rosie. One of the things that was most impressive to me about this work from afar is how deeply the cast of characters across the county had embraced vital conditions. So when it came time to hire a new county manager, the job talk in public on YouTube was, how are you, our prospective county manager, going to help us implement the agenda around vital conditions? So every job candidate had to stand up and say how they would take the baton next in the role of county manager. That is, when we're talking about data and signs of progress, that kind of commitment doesn't happen by accident. It happens through the work of colleagues like you and the team that you're working with. So thank you so much for that story. Liz, please help us understand what this work feels like with you and your colleagues in North Sound.
Bobby, thanks so much. And I just have appreciated getting to hear the two panelists so far. I have a couple of slides because I'd like to first just orient folks to where we are in Washington. So the first slide is just a map of Washington state. And we are the only state in the country that has these accountable communities of health covering the entire state. And that allows us to do some things that are cross-jurisdictional, thinking about both what happens locally, what happens regionally, what happens statewide. And so in the next slide, I wanted to just pull out what is North Sound, because in the state of Washington, we have these 9 ACHs, but in North Sound, we are 5 counties, all of them north of the Seattle, King County area. And that is the traditional homelands of 8 of the 29 tribes in Washington state. And it's been really significant because thinking about land and, for us, the waterways, each of those 9 regions are really unique, but we have some common language and some common agreements about how we are approaching the work, doing cross-sector collaborations and investments. And that work began, even for North Sound, with an agreement with the Center for Medicare and Medicaid Innovation, CMMI, and then 3 years later led to Washington having the first of what is now 2 Medicaid waivers to invest in these regions and the approaches to do some connections between clinical and community-based innovation. But for North Sound, I just want to point out that we have got 2 counties that are separated from the mainland by a body of water, the Salish Sea, or what's probably known across the country as the Puget Sound. And they might be one county, but every island also has its own identity and wants to control its own destiny. So when we think about the work that's occurring, we have to think locally, regionally, county jurisdictions, what are the cities doing? All of those pieces are at play. But the call out there that shows the 8 tribes is really important to us because of the fact that that's where we sit, is on those traditional homelands. And so back in 2018, we began what we refer to as a tribal and equity learning journey, wanting to have all of our partners across this region understand the legacy, the stewardship, the richness and generosity of this space that we think is incredibly special and beautiful, that so much of it is because of the leadership of the tribes, that is what protects our waterways, protects the salmon runs, that they have standing with the federal government that we do not have. And so that relationship has just been really important. So tribal sovereignty is one of our grounding frameworks, and everything else that we do is intertwined with that, not additive, but intertwined. And so our frameworks include equity, targeted universalism and belonging from the work of the Othering and Belonging Institute, the vital conditions for health and well-being. And then in the last 2 years, we've added a set of principles around leading with love. Those things all comprise how we approach the work. And we have partners who are helping us in telling the story of not only what's the value, but what's the opportunity if we actually get a little bit better at understanding each other. And so on the next slide, I just wanted to lift up a couple of things that come from someone that I just so admire, Nicole Maher, who is the president of the Inatai Foundation based here in Washington. And at a talk that Nicole gave, she pulled up these 3 stats. The one in people watching is a blur and or an immigrant. That 47% of the children who are in public school are people of color. That those who are between 0 and 5, the most diverse portion of Washington's population. And the quote that just stuck with me, that we need to imagine a state that's ready for them to lead and design the future that they want for themselves. And so we just kind of keep coming back to that. How do we actually give voice, create space that isn't about what my old self wants to design for the next generation, but how do we pull some of that forward so that we're actually hearing from and actually leading with what communities want to see in place? And so the last slide that I have, and then we'll turn the slides off, is really how did that change the work in North Sound for us as an organization? And so as you can imagine, we had a vision and a mission, and our mission or vision was something like improve the health of the 1.2 million people that live in our region. And after intertwining those different frameworks, at the end of 2020, our board actually scrapped the vision and the mission statements and replaced it with a purpose statement, because we were facing why do we need to exist? Is there a reason for us to be in this space? And what they came up with, it's to create a just and inclusive culture and the necessary conditions for all community members to thrive. And that was driven by those intertwined frameworks that we had in place. So we can remove the slides now. Thank you so much for pulling those up there. But our focus has been looking at our region, certainly region-wide, but if we take targeted universalism as an example, how do we assure that there is space for those who are furthest from access, furthest from justice, furthest from equity, that if we're actually going to do these things, that's where we start. We can do those things focused on populations that don't have the easiest way during, for example, whether it's COVID or we had a climate event that was a greater than 100-year flood that impacted 2 counties, that the people who were not being served were the folks that we were actually the most concerned about. And it has led us to, we use storytelling, videos, radio to try and reach different communities during the COVID crisis. We had to use those same strategies during the flooding. And what that has led to new partners coming to the table who never saw themselves being part of a regional collaborative in any way, going, oh my gosh, you mean you have space at this table for me? Would never have imagined that. And that has led us to initiatives around language access, working with young leaders, especially some young tribal leaders who are coming forward. And our work comes through this notion of the vital conditions. And the last piece I'll mention is that we have about 180 partner organizations across the region. And 3 years ago, we decided we were going to take a part of our budget and we were going to let partners decide how those dollars got used with other partners. And so we're now entering our third year of a review committee comprised of partners who get submissions from other partners, and they get to distribute $3.5 million to try and decide where is that investment. And the investment is all focused around the vital conditions. And so it's been really exciting to watch them make decisions about what the investment should be in communities. And I'm just looking for dialogue. So thank you all so much.
Thank you, Liz, and each of you for sharing what is clearly passionate work that is not just a day job, right? This is work that brings our full hearts, our hands, our heads into it in new ways. And I was at a meeting recently where they opened with a quotation that all learning happens at the borders, and you can think about, like, we've got stories of borders here, literal national borders, tribal borders. We've got borders of where the investment has been and where it hasn't. We've got, we're living in an age of so much division and fragmentation, and, so much of our medical industry divides people into disease and body part and population groups. And, clinicians throughout history have sort of done personal histories, and then they look at vital signs at an individual level. What I'm struck by each of your stories is that you told a social history to understand the vital conditions in communities and what that means to do this work. So I'm wondering if we could just talk a little bit about what happens when we don't lose sight of the individuals, but we put them in context, when place matters, when love of people and place. And I use that love that has shined through in not just your affect, but also your language here about bringing love to the foreground in this. So talk a little bit about what that feels like when you're interacting with people, when you're, committed to the health and well-being of people, but it's got to run through place and through culture. I'm seeing lots of heads nod on that one. Sam, why don't we go back to you? What does that feel like in the room when you're with people who are starting to work in these ways?
I think traditionally, as we have tried to work to improve social and economic factors, our society is set up in such a way that there's silos, right? And we are pushed to think about our own organization's outcomes or the viewpoint that we are bringing to a particular issue. And that doesn't lead to that sense of collective. It leads to us sort of owning our piece and thinking about how we need to sort of survive as opposed to really connect with others. And so I think the most impactful thing is to see our partners, both within the healthcare system and in the community, be able to put the collective of a community ahead of their individual organization or outcomes of that organization. And within that allows people to really get to know one another. One of the, Liz, you had said, people understanding each other and having that empathy, that is only done by relationship building. And that enables us to keep coming back to the table. I think that is the harder part. It's easy to come to the table originally and say, yes, this is great and we should all do something together. And then the going gets tough, and, finding the win-win that works for different organizations, or the policy that we have to change, or the barrier that's getting in the way for us moving forward. It really requires that we know each other at a level that we can talk through that and lead to a productive solution. And so I think that's been the most fascinating part to watch as we've been doing this work, is that it really creates spaces for people to just get to know one another better, get to know what our shared values are, because from that place we can move forward together. From that place we can think about what the solutions are, or how we have to do differently. And it helps to break down those silos, or make sure that we're not doing things within our individual sectors or organizations that are in the end easier for us, but detrimental for the community overall. So I think that would be my initial response to that.
Lovely.
Yeah, and Bobby, can I just be additive to that? And, so think about the number of ways that you're hearing about work happening in communities and what are the measures that folks look for. And so through the first Medicaid waiver, that was like 2017 to maybe 2022, it was all focused on like behavioral health integration and addressing the opioid crisis and like all these very clinical things. And there were these questions that we would get from the state healthcare authority. So what's your sustainability and what's the strategy that you're going to use? What do you think the impacts are going to be? And so as you can imagine, it's like, oh my God, we're going to reduce like the trend in emergency room usage. We're going to like decrease this. And we wrote, it's all about relationship building. I said our sustainability model, that people who do not know each other in the community are going to learn who each other are, how they can work together. And when you say like, what are some of the surprising things? It would be being in a room with two organizations that literally had their offices on the same block and had never known that those two organizations existed in the same community, doing the same or kind of complementary kind of work. And then watching them come up with a project that they could work on together. That notion of how we actually start to, I'm really in this notion of like weaving a piece of fabric or something, how we see these things that we do as not being siloed and separate and distinct, but being intertwined. If we're working on behalf of the community, they want to see the network and the patterns and how can I connect this to this without having to start from scratch each time they knock on another door?
Yeah, it's a great point. And, there's been decades of research showing the value of collaboration, but it hasn't generated lots of investment in that collaborative infrastructure. So one of the things that was intentional about crafting the Vital Conditions Framework is to describe what is produced when people are feeling connected, when they're really contributing. That's what belonging and civic muscle is. And Rosie, you talked about this work being about investment, about being able to bring resources to the things we value. And if we value relationships, if we value networks, if we value people feeling like each of them have a part of the thing, then how does belonging and civic muscle become not just visible, but also investable? I'm wondering if you could speak a little bit to that.
I think one of the pieces I'll say, I really appreciate Liz and what she shared about leading with love. That's actually one of the frameworks that the incoming county manager at Doña Ana County leads with, and what everyone is very excited about. And for it to become tangible, to be able to see that we're leading with love and there's collaboration, you have to change how you've done business for years as a government, as an entity. And I was reflecting of the responses of both of the panelists. We have to understand that community is angry, community is hurt, community has been exploited, whether it was on purpose, whether it was inadvertently. And there has to be an effort for us to realize and say, those before us have either succeeded or failed, and we're owning that. There is a sense of disillusionment, we're aware of it, and we are going to overextend ourselves and change our ways in working with community so that we do no more harm. And so when you first make this effort, that first piece is going to be a long-term effort to invest and overinvest and engage, bringing individuals, for example, into participatory budgeting. So that's the pieces that we're looking at as far as saying, how might we share our work and share at the table which infrastructure projects we need to invest in with community and change that process. What does that look like? How does that lead up to the strategic plan? Another is having presentations done, work done in collaboration with community and presenting that to White House stakeholders when we're writing national grants. The voices of community need to be upheld. They need to be heard. They need to be amplified. And that demonstrates a sense of respect that may be missing in certain communities. Once, from our perspective as a Mexican-American community, respect speaks volumes. Respect, loyalty, appreciation for hard work. And so we have to speak those languages to our community. They're demonstrating how we change, how we meet. For example, when we're at council, at commission, Even the setup is intimidating. We've had individuals tell us, here I am in front of the dais looking at all of these people down on me, and I have 3 minutes to speak and I have to speak quickly. How can we change the dialogue of how we talk about policy? So much of what we've done historically has to shift. And then you'll see the tangible results of more people coming out to vote, more people getting engaged, more people speaking authentically and with respect when we disagree.
I'm sensing the scope of those learning journeys, which can feel immense to a lot of people, but it just starts with yourself, right? It starts with your organization, the close partners. So much of our healthcare enterprise, oddly, an industry set up for healing relationships, has become detached from people in place, and so just forming those attachments is what I'm hearing each of you talk about, and then it can grow through those strong, trusting working relationships. I'm also struck by another similarity in your stories, which is none of you are sort of narrowly devoted to a single framework. You're looking for what works in context. This is not about, sort of following a script of a particular theory and trying to prove it right or wrong. This is about taking action, looking at the reactions, and figuring out what works in a relentless commitment to, create that culture and those commitments that matter. And so maybe can you just talk to me about the discipline that it takes to be able to look for any idea that will work and try to put it into action as quickly as possible. I'm seeing that in your practices here, that this isn't so much about slogans, it's about what can we do through action and through action learning. Maybe we'll talk to this idea of multi-solving, right? Because that may be the expression of using multiple frameworks that ultimately say, can we advance many of our goals at once? So I heard all of you speak about multi-solving, but Sam, I think you mentioned it first. So what's backing that commitment to being multi-solving?
Think that we have limited resources, and we know that there's no one solution. I think our learning over time has been that adopting a singular model will have its pros and cons, and that by bringing multiple frameworks or models to the table, we're able to maybe build on the weaknesses of one or the other to really add up to something more. And then that helps to pivot. We can't just say anymore that it's just housing. The thing I always say is embrace the complexity around these issues. It's housing and education and sense of belonging, and we can't isolate them, right? So it's how are we all contributing to solutions that will hopefully address one area, but by doing so are going to have ripple effects on the other areas as well. And I think in doing that, then you need to have multiple frameworks that you're pulling from. You need to have multiple leaders. I think that also helps to validate and lift up the work as well. So one sort of easy first step you can take is think about who are those leaders across the country, like the Ripple Foundation and Bobby, the leadership that you're providing around bringing that voice to your local community. One of the first things we did was start a speaker series, and Bobby was our keynote for that to start, because it's not just about us believing this, but it's starting to spread that word more broadly in small ways and in lots of different ways. And that's where you see that language be adapted. And for the healthcare system, vital conditions might make more sense. But for someone who's in, the housing sector or community organizing, it might, resonate, a different framework might resonate for them. And so I think also having multiple languages that you can speak depending on the person and the perspective, it just creates that flexibility that does actually create a space where everyone can fit in, right? Because we have something that will speak to everyone. So I think the multi-solving piece is really acknowledging that isolating these things we haven't seen significant improvement in outcomes over time when we try to isolate. I think our next phase here is to really embrace the interconnection of them and then think about how do we address that from multiple ways and see if that leads to a more impactful and sustainable outcomes over time.
Rosie, Liz, thoughts on this question?
I have like two examples that come to mind. So one of our smaller counties, Skagit County, because of some of this work of being introduced to targeted universalism and belonging and the vital conditions, their county council and the mayors of 4 of their cities adopted the vital conditions for well-being. And it was really amazing. And so they built this table of kind of crossing county. And I mean, I say that going jurisdictionally, crossing counties and cities is really, that's like a body of work unto itself. But they have this table that includes the mayors and then includes community partners. But they started with what I think is like a really hard topic, but it was one that's driving their budgets, which is the relationship between behavioral health and lack of adequate and affordable housing. Like they wanted to use the vital conditions framework to try and help them come up with some cross-jurisdictional solutions. And to Rosie's comment, and they said, we're going to use the vital conditions framework for our next budget cycle, just to like have them have that framework. And so it's been amazing to watch that in place. But like as a total aside, because of relationship, the person from their county elections office reached out and said, hey, North Sound ACH, I hear you do kind of like outside the box things. We'd like to have our 2024 election materials in both English and Spanish. And we said, now you know, that's kind of related to belonging and civic muscle in the middle of the vital conditions framework. I think your county would support that because they're committed to that framework. And so we helped them through the last year. We thought it was going to cost money, but they actually did so much of the work themselves. And for the first time, a county that is nowhere near meeting the threshold that the Voting Rights Act requires is putting their materials in English and Spanish for this election year. And it has led to 2 other counties, like it hits their competitive nature, who also don't meet the required threshold, going, well, if Skagit can do it, oh my God, then we should do it too. And they're doing it because of this notion of belonging and civic muscle. How do we have the people in our community feel like they don't actually have to put in a request? We're doing it. We're doing it because we want them to have this better access to what I think is like the most critical component of civic muscle. It's the ability to vote. And trying to change from, hey, can I have an interpreter, to us putting on every meeting, we have interpreters available, you just need to tell us which language. You don't have to ask for an interpreter. We're going to presume that we will have that resource available. We just don't need to know like which language. Those small things change people's like just premise. Do I belong in that room or do I not? Am I invited into that space? Are you prepared for me to be in that space? And I'm just so excited to see what, like, does the voting pattern change in Skagit County at the end of this election cycle? But it's watching people do things because of the framework, not because federal law is requiring them to make some kind of a change. And I think that's incredibly impactful.
Rosie.
I just wanted to tell Liz that the Skagit County was actually one of our inspiration points and mentors. And one of the reasons why we had the audacity to think we could do this, because they expanded beyond their own jurisdictions, and we had different phone calls with them. So I just want to pass my gratitude to your colleagues and demonstrate how their inspiration is actually being realized here in the border area. I just have 4 things real quick, 60 seconds. Having the moxie to challenge it, you have to have that persona of maybe that level of ignorance. Is that actually the catalyst you need for innovation and for change? I didn't know any better. I didn't know that we couldn't do that. Well, now, we're not doing business as is. Have that mentality to challenge change. Also, we are looking into multi-solver cafes every quarter as part of a work session for our county commission. So we're bringing forward a very inspirational idea from community and testing it, piloting it, seeing what we can do. And then thirdly, for those that are in government, you are organically set up to have multi-solving discussions. You can bring together community development, transportation, public safety, and they can bring all of their challenges and identify one cross-cutting solution that can be financed through county budget if we were just to change the way we talk to each other.
Well, this conversation among us today has changed me already. I know you, and I know your work, and I visited the places that you're talking about here, and that is my wish for the people listening today, is that you turn toward each other in this moment when so many are turning away. Turn toward each other, turn inward to yourselves, and we will find a kind of humanity that has sort of yearning to be expressed in this work. Um, and and just the magnitude of change that is within reach is reason enough to say we're not limited by anything. We are capable of making great strides in this work. And I think all three of your stories illustrate that in indelible ways. So thank you not only for today, but for the work that you do every day.
Thanks so much, Bobby.
Thank you.
Wow. Thank you all. Your work serves as a powerful example of how the Vital Conditions Framework can be put into action, creating fair opportunities for good health and well-being across diverse communities. Next, we get to hear a change leader's perspective. Mayor Ramiro Garza from Edinburgh, Texas, was not able to join us today, but he recently sat down with Bobby to discuss community engagement. Mayor Garza is a passionate advocate for health equity in his community, spearheading initiatives to improve access to healthcare, nutrition, and active living, especially in underserved neighborhoods. And I'm proud that he is an active participant in the Move with the Mayor initiative. Mayor Garza and Bobby.
Thank you, Mayor Garza. It is a treasure to be with you to talk about something that I think a lot of people in the audience are really curious about, which is, we know that there's immense potential for people in communities all across the country to really create conditions that are built for everyone to thrive together. And you don't have to be an expert in a special framework or have special language to know what this looks like in practice. And, the reputation of what's going on in Edinburgh is traveling to, far and wide. So I'm wondering if you could give us a kind of a firsthand view on where the energy for improving, well-being in Edinburgh is coming from. Who's showing up to do that work, and how are they charting a, kind of a path forward?
Yeah, so thank you. And again, thank you for having me take part in this. So it's residents in our community that have come together as part of this initiative that we have, Edinburgh 2040. And it was a way to have City Hall connect closer to our residents. Edinburgh is a county seat here in South Texas, meaning that the county courthouse, for example, is in our city. We're home to the University of Texas Rio Grande Valley. We have two major hospital systems. And what this has done is has brought those stakeholders together along with residents and participating and improving our city. And regarding health and well-being, we participated with our Move with the Mayor campaign, and that initiative really exemplified our commitment to promoting active lifestyle and building a more connected community. At that event, we have over 100 residents. Our actually superintendent joined us. We had a university leadership individual that joined us as well on this walk, and really simply to just get moving and promoting, community engagement. These walks encourage our residents to incorporate, this physical activity in their daily routines. And it's just really helped generate that awareness. The same spirit related to the health and well-being is also in place with several other key factors, or I should say focus areas in our community. This Edinburgh 2040 involves 8 different committees, from transportation to parks, economic development. We have a youth advisory council as well, a cultural arts initiative as well that brings events to our city every year. And so it's people throughout our community, residents that have an interest in these areas. The good news about these committees is that you're not having to get appointed by the city council. You simply could sign up. We have a website set up, our Edinburgh 2040. You just sign up which committee you're interested in, and you take part in that committee. For us, it's really helped us, have our residents engaged, and we're taking note of that. A lot of the recommendations that committees are coming up with, as an example, adding sidewalks in our city, has been adopted as part of our annual budget. And so we look forward to continuing this initiative. our theme is Edinburgh is for everyone. If you have an interest, for example, our Indian community, we're going to bring an Indian festival, well, let's have that, and let's have it here, and let's connect it together with another culture event where it's all about bringing our community together. And I think that's what our goal is, and we look forward to continuing to do that.
Such a lovely expression of the idea that we can create, kind of that sense of belonging. But once more people feel they belong, there's kind of so many opportunities for people in every walk of life to contribute, to build that civic muscle that makes us be able to do great things together. You mentioned that there's sort of a wide-ranging plan around this work and activities happening in many arenas. Can you just give us a little window into the kind of investments that are going into this? Like, it does not just budget, but the kind of leadership energy that's going into this work, but also budget if there are real dollar signs behind it.
Yes, thank you. So these committees have been meeting. They help us really keep an eye out on the things that I think we should be focusing on. As city staff, I think we sometimes we're at City Hall and may not see beyond what a particular neighborhood, for example, a challenge may be, and so that's where these committees come into play. But as a result of their recommendations, in the last 2 years, we've approved over $10 million worth of improvements throughout our city. And these are improvements related to street improvements, for example, adding sidewalks as well, drainage, that's an important issue here in our community, lighting throughout our community, and then quality of life initiatives too. We've added parks space and expanding our trails as well, as it's just some example of what we're trying to do. And we're also helping our small businesses. There's a need for revitalization in our downtown. We call a FLIP program, which is a program where we match up to a certain amount to improve their facade, and that way they can put some fresh paint on their building and get customers come into their business. All these efforts came as a result of these, and we, again, going back to being the county seat and being home to the university, we have so many new people moving to the area. We're the 11th fastest growing city in the whole country based on the latest population estimates. And so we have to make sure that we bring everybody together. There's a lot of new people moving into the area, whether it's to the university, the hospital system, with the School of Medicine. It's important that we stay connected with the community and that we make improvements that are needed and that the citizens deserve. And that's what we hope to continue to do.
Yeah, it's a really fascinating story of how when you create space for people to sort of make their vision of a healthy, vibrant, connected community become real, and you bring the institutions to help realize that, just how much can get done. This is a lot more than just preventing heart disease and stroke. That may be one of the consequences of this, but you're creating conditions for people to thrive, is
Correct.
what I'm hearing.
Correct.
It's totally impressive. I just want to revisit in our last moment here. You mentioned that a lot of this was coming from youth. Can you just describe the special role of youth in this work?
Absolutely. I think it's so important that we have our youth engaged civically. And in order to do that, we thought we would involve them early on. We have a youth advisory council. We invite and have them apply every year. We select 3 juniors from each of our high schools. So we typically have 15 to 20 students, participate, and we're taking them through a leadership program through our city government and learning about our government, learning and hearing from them. We always get results. I'm always surprised to hear what they ask. That I sometimes think that they're going to ask for things related to youth, but they want a lot of the same things adults want. They want entertainment. They want to be able to stay in our city. They want walkable streets. And so it's been a joy to have them participate and also having them provide that feedback to us.
Thank you for sharing your story. It's just a good example of how much we can do when we're not just focused on programs and projects and policies, but getting enough people to care about creating a community that is healthy, that is equitable, that really has room for everybody in it. So thank you for all the work that you're doing and for sharing your story today.
Thank you.
Thank you, Dr. Milstein and Mayor Garza. It's really exciting to hear how Mayor Garza is engaging community members in Edinburgh 2040 and using Move with the Mayor, along with your other initiatives, is making an impact on the residents of Edinburgh. Mayor Garza, I'm delighted that although you couldn't join the panel live, you're here now for this Q&A session. So thank you very much for joining. We thought about doing a switch here, but your interview was just so good that we ran with that. We appreciate your joining us now. Rosie commented toward the end of the session that government is uniquely able to bring different stakeholders together. And then you followed, Your Honor, with a present day example of exactly that with Edinburgh 2040, where you're not just leading a whole of government approach to creating conditions for people to thrive. You're allowing for community input to inform and even drive decisions. I love that the decision about building more sidewalks came from community members. So one reason I'm so interested in this particular panel is that you, the three of you, represent the three sectors: public, for-profit, and nonprofit. One thing that stood out in each of your comments is that your organizations are leading and at the same time collaborating across silos. I wonder if you could give one comment. What's one sort of breakthrough idea that you've learned through your work about how to bridge those silos successfully? How do you bring people into an inclusive process that strengthens the vital conditions, creates the conditions for people to thrive? Rosie, I quoted you, so let me put you on the spot to begin.
Sure. Well, I saw a comment earlier from one of the individuals, I think her name was Meg, about the similarities or some themes with collective impact. And that framework really does support the vital conditions. So a couple of things that have been very helpful. One, we do have to find a common agenda. It's mostly pain points across, departments. And when you bring that to the table and say, we can work together to address your agenda as well as everyone else's, there's more engagement. Another piece is, and Liz and I had talked about this earlier, just like demonstrating a culture of respect and gratitude for community residents, making sure that they're at the heart of everything and that they're going to be respected and heard. And then there's going to be action as a result of them being at a session with you. So those are two big pieces that we've seen a lot of success with, is just really the follow through, and not just how you're doing your plannings or your meetings, but the actual follow through.
Liz?
Yeah, and thank you, Rosie. The two pieces I would add are allowing time for relationships to be formed. Like, we're so used to jumping into the work that we forget that really the power in community is people getting to know each other and learning how to work together. And then I heard this, Mayor, in your comments as well. How do we actually demonstrate that we trust the community? How do we listen, actually take what we're hearing to heart, and don't double question it or triple question it or turn around and go to an expert to verify what we're hearing from community? That, both creating those spaces, letting people get to know each other, and then just being able to demonstrate that we actually trust what we're hearing from community. We're willing to take action based on that. Those feel really important to us.
Your Honor?
Yeah, well, thank y'all so much. I really, appreciate the opportunity to be here with y'all. It is for me, I'm not sure if y'all know my background, but I like to say I come from the inside. I was a city staffer myself. I serve as city manager. So my perspective obviously is very different. When I was running, I obviously had a different mindset when I was trying to ask people and campaigning and voting for me. But one of the things that I noticed, because I was always in the inside and now running for office, is, like there's just a big disconnect with City Hall and the residents, right? And so our whole idea of forming this, Edinburgh 2040 process just to get citizens engaged. And I mean, time after time, I would hear, well, I'm seeing you now. I'll probably see you again when you're up for reelection, right? Because that's just how it is. And I'm a politician. I could say that about ourselves, right? And I obviously was really moved by that and made it a point to make sure that that was not going to be the case with me and our administration. And so that's part of this initiative. But I think, Rosie, you hit on something. It's important, is that people want to be heard, but not just heard. They want action, right? And so the follow through is so important, and that's why these committees that we set up were not set up to meet on their own. We actually have a city staff person related to that issue, whether it's parks or infrastructure or economic development, that sit on those committees, and there's minutes taken by them. And then we've taken it a step further. We actually have integrated their recommendations into our budget process. So we've actually approved, as I mentioned, over $10 million of improvements that came directly from the 8 different committees that we have. And so I think back to Rosie, I really appreciate your comments on that, because it's really kept our residents motivated. We have over 100 residents involved in this, and them seeing that wow, the idea that I had to connect this sidewalk to this, is actually included in the city budget. And and for us, sometimes when we're at City Hall, it's hard to see beyond City Hall, right? It just is. You get bogged down with so many things, that are happening. So they thank us, but I thank the residents. I said, look, you all know your neighborhoods better than anybody. So, your feedback you provide us is helping our staff see and add, things to our budget and our priorities that it would be hard for us to add if we weren't in your neighborhoods. And so, I think that's what I will add to this. It's keeping citizens engaged, but also making sure that they're seeing results come from that.
Thanks. This may show my lack of understanding of the vital conditions, and in particular, civic muscle. When I hear people talk about it, when I read about it, I think of it in terms of how do we help people, individuals in the community, feel like they're part of the community, and how does that create civic muscle? I feel like in the examples you've given, you've flipped that, and it's the involvement of community members that have added muscle to the community. Is that an accurate way to look at it, do you think?
Well, I believe so. Because look, the other way to look at this, right, is, well, you were elected, by the residents, so the decisions you make should reflect, right, the voice of the residents. But to me, when people go vote, they go vote, and then they're not involved, right? Because there's not a structure for them to be involved. And I think for us, this is a way for them to get involved. And so yes, I would agree with that. It's just a way for people to be involved. If you want to be involved, there's an opportunity to do so. And what I love most about our Edinburgh 2040 program is that you don't have to get appointed by our city council. A lot of people, when they ask them, serve on one of our boards, they just don't feel like submitting their information to the city. They're private citizens. And but this Edinburgh 2040, we have a website set up. You can just go in and log in and just sign up your information, and you're in. You don't have to be voted at a public meeting, right, to be appointed to a board. And so I think it's just made it easier for people to get involved.
Thanks, Your Honor. In her comments, by the way, if you have questions, if you're in the audience, you have questions, please use the Q&A function to get them to our panelists. We'd love to hear them. Sam Schock, in her comments, she talked about people putting the collective of community ahead of their individual interests. And that's certainly a current that we see running through a lot of discussion and debate in the political sphere and elsewhere in current day society. I wonder, in the context of the vital conditions, is that collective good and individual interest, is that a trade-off? Or does making a thriving community a shared create an environment that enables individual stakeholders to thrive and to reach their goals? Rosie, what do you see? What have you observed from your vantage point there, in the borderplex?
No, that's an excellent question and quite a hot button. I think because you're talking about shared power, and when you introduce the language shared power or shared influence, you're introducing an idea that you have more or I have more, and as a result of us coming together, one of us will have less. And I just listening to the Honorable Ramiro Garza, I know you're a Texan through and through because you said y'all. So I know that you're from the from the great state of Texas. And I think at least here on the border, some of the things I've seen is this zero-sum game. And that's a myth. And that's not a reality. And that we have to undo that type of culture that where one is elevated or one succeeds or is moved further away from a place of inequity. Someone else has a loss. So that there's a whole cultural shift there, John, that we first must address. And that is, to Liz's point, takes a longer time to establish relationships, trust, and then start to change the lens of which we look at things, where we all are thriving, if that makes sense.
Yeah, absolutely. Liz, I hear Rosie saying this isn't pie. If somebody gets a piece, that doesn't mean there's one less for you. Is that accurate? And do you find that, if so, does that resonate in the Pacific Northwest?
Yeah, and again, each of these comments is making me think about different things, but I think that if we think about our communities as being a whole, that if any segment of the community is doing better, the whole community is doing better. That when we start to think, oh, there's a trade-off, and know that in the public sphere, trade-offs are always a part of conversations. Like decisions sometimes involve that kind of negotiation, but in terms of belonging and civic muscle, it's how do we turn that conversation, pivot it, that if a group is going to do better, that means we are all doing better. It's really when we try to segment, I want to do something better for young people, and we think that that's separate, and I'm somehow saying I'm not going to do things better for seniors or, working adults. It's really getting us to a point of seeing our whole community and how do we have different strategies to lift up everyone in our community.
Yeah.
That's when we get to that building that civic muscle. And, we're certainly at a moment in time where, our strongest civic muscle is the ability to vote. And that's like a moment in time that doesn't come every day. But what, you're hearing Rosie and the mayor talk about is it's not only at election time, it's every other time. How do we build those opportunities for people in our communities to exercise that civic muscle and get better at it? And the more we do it, the better our whole community will be. I'd like to think of us as not trying to segment the pie, but that every piece of that pie is making the pie richer and better and just like more nourishing to our community.
And can I just add to Liz's comment? I really appreciate it. If one part of our community is doing better, we all do better, as long as that community is not benefiting as a result of other communities.
Absolutely.
Yeah. Mayor Garza, I want to go back to a question that Warren Jones asked the previous panel, or a variation on his question. I think we're all familiar with the backlash against diversity, equity, and inclusion, or DEI, and that's loud and visible to all of us. And in some states, it's even taken the form of policies that discourage, and in some cases, even prohibit employers and others from implementing DEI principles and strategies. So there's a frequent criticism we hear that the equity improving agenda, which I believe all or nearly all of us who are gathered here today support, is about imposing one faction's values on others, to the point that all of you just made. That it's an extension, really, of the criticism of public health that it's part of the nanny state. And this is why the National Forum has for several years been helping health equity advocates meet all Americans where they are, including white people and conservatives and those who are champions of individual liberty, and raise understanding that health equity benefits everyone. It seems to me that this is one of the ways the vital conditions framework is so valuable. Sam said it, I thought, really well when she said it aims to attract investment upstream to create conditions for people to thrive. So I think what I've heard from all of you is that vital conditions is about empowering people, not dictating to them. And it's about expanding opportunities for people to make healthy choices every day, not limiting their choices. So, Your Honor, you're an elected official in a politically conservative state. And I wonder, do you find that the vital conditions framework gives us language that can help more people see how equity benefits everyone and not just members of certain groups or classes?
Yeah, no, thank you for that question. I'm going to, again, refer back to our initiative, because that's what I know, right? Our Edinburgh 2040 committees. One of the things that happened is we did a survey first. We didn't just create, committees. We did a survey of our community. Our local university helped us with that. We had over 2,500 people fill out that survey. So our 8 committees were formed as a result of 8 different focused areas, right? And so, part of that is to ensure that whether it's planning for better parks or more accessible health services, we just wanted to ensure that every resident has a say in the policies that affect their well-being, and make sure that it's community driven, right? Because at the end, we as a council have to make those decisions on what it is that we prioritize and fund. But it makes me feel really good in our budget when I actually have staff add in there, these came from a 2040 committee, like these line items, because those are coming directly from our residents. We have all our meetings are public meetings, but as y'all very well know, we don't have very many people active, right, in communities around the country. People, when you tell them, well, we had a public meeting on that, they said, we're busy. We didn't see the notice, or it's just the way it is. But people are going to these committee meetings because they feel their voice is being heard. And so I feel that because we're covering our bases through these different committees, having the needs of the communities based on the survey, I feel that's pretty equitable, and it's giving everybody an opportunity to have a say in what we do as a city, and more so than just going to vote, more so than just going to a public hearing, and expressing their opinion on something or other. And that was the whole point of us doing that. But going back to your question, I do feel, based on what we're doing, we're allowing for the community at large, right, to be impacted in a way that before this, it's tough, because we make our decisions at City Hall. that we think is in the city's best interest. But how do we know that if we're not asking our residents? So I think that's a way for us to do that.
Great. Thank you. Rosie, if you can comment, and then Liz, you get the last word.
Just in regards to how vital conditions is furthering equity, what's that?
Yeah, do you find that it resonates with more of the public, more stakeholders than some of the other rubric that we've used in the past?
Absolutely. Absolutely, because it's almost as though some of our practitioners, and coming from a city or a county background, the departments of roads and engineering that I had highlighted earlier, they can see themselves in that reliable transportation, being able to talk to sheriffs and law enforcement about public safety. And so when we've hosted different vital condition sessions, the department leaders get very excited. When you translate it into the residents, it feels less academic. It feels more relatable when you're talking about things. And some of them may, for example, the natural thriving environment, that label felt a little different. They were thinking about like healthy environments. But they grab onto it and they feel that they can own it. And so if you're presenting something to a community resident that doesn't feel relatable, doesn't feel within their reach, they're not going to want to continue. It'll feel like it's being forced upon them. So the vital conditions framework, from what we've seen, has been exciting to hear their feedback on. We had a survey that had gone out with an initial baseline in certain areas of the colonias about feeling civically connected and having pride. And anywhere from 36 to 50% of our community responses from those thousands of surveys had said, yes, we do. We care about our county. How do we get those individuals to show up, though, at our town hall, at our county meetings, at town hall meetings, as the mayor had indicated? How do we translate that to next steps and actionable items? And we're hoping the vital conditions does that.
Thanks. And what I heard in your answer, actually, I was hearing echoes of an earlier question about how does all this connect to cardiovascular health? And so as Mayor Garza was talking earlier about better lighting in public spaces, on the streets, and building sidewalks where people can safely walk. We know we can connect those dots. We know that those things that enable people to be more active every day do help control their blood pressure, do help reduce their overweight, do help to prevent diabetes, high cholesterol, other cardiovascular risk factors. So the dots do connect within this framework. Liz, in the Pacific Northwest, on the northern border, do the vital conditions resonate widely, or is it just with certain people?
Yeah, probably like two things. First, I'm going to just say the northern border is also seeing people coming from, Argentina and Colombia. Like, people are they're traversing our borders in really intricate ways. So I think our borders are, potentially more porous than we think that they are. My oldest son speaks Chinese and Korean, and one day I was going on about the fact that I have no skill set in additional languages. And he said to me, but Mom, you speak bureaucratese and health policy ease. And the thing about the vital conditions, that framework speaks to people in a layperson, non-policy wonk language. Like, there's so many pieces about it that are not necessarily new. But if you're listening to community and what is important to them, those elements of the vital conditions framework speak to them in ways that the social determinants of health and other, frameworks we've used in the past do not. And so they're seeing, oh, you're actually talking about my well-being, my ability to thrive, my ability to actually interact in a community that I understand. And to those 3,500 people,
that the mayor is responding to, the social connectedness that begins to occur when people actually are coming together and seeing each other, weighing in on things, those all improve our health. I mean, they're the interweaving ways that these frameworks come together are profound. And so before we adopted the vital conditions framework, we had about 50 partners that we were working with. And this week we hit 204 partner organizations that are coming together around the vital conditions framework. So it's capturing people's imagination of how the different aspects of our communities are connected. And I think people are excited to see the opportunity that sits in front of us.
Well, thank you for sharing your insights. Liz Baxter, Rosie Natividad, Mayor Ramiro Garza, thank you all so much for sharing your insights, your learnings, and your success stories with us. They're valuable. I'm excited to invite our Director of Programs and Certified Fitness Instructor, Jen Childress, to lead us in a brief at-your-desk stretch activity. This is a great opportunity to shake off any tension, improve your focus, and get ready for the important discussions that lie ahead.
Hey everybody, let's break up this meeting by getting moving. There'll be music on in the background, so just follow along with me and most importantly, have fun.
Thanks, Jen. We've now arrived at our third and final panel for the day, leveraging the power of data-driven approaches to improve and sustain the vital conditions. Dr. Bobby Milstein will once again facilitate the discussion.
Thank you, John, and welcome to the third panel in really what has been a fantastic day spotlighting innovative uses of the vital conditions framework. The purpose of this panel is to focus on the interface between vital conditions and data. We're going to hear state-of-the-art examples of folks who really are learning firsthand the power of data and new data platforms to establish vital conditions with a clear focus on equity and racial justice. There's so many things that data can do. It can help us clarify aspirations. It can help us identify assets and opportunity. It can help us negotiate priorities. It can help us chart progress. The sky's the limit, really, when we're committed to being curious about where are we now and what's it going to take to make a great stride forward toward well-being and equity. We're also going to talk about the who is involved with this work. We'll discuss the critical importance of bringing diverse perspectives into this, to do collaborative sense-making, storytelling, case-making, those kinds of things. The data don't always speak for themselves, and we have to bring the points of view together to understand what it means and particularly what does it mean for the kinds of actions that people are going to take next. I am joined by some of my favorite colleagues in this work, with whom I've learned much of what it takes to do this. We've got Roxanne Medina Fulcher, Executive Director of the Institute for People, Place, and Possibility. Sequoia Rent, who's the Chief of the Bureau of Health Equity in the state of Delaware. Jasmine Hutchinson, who's Community Benefit Director at Loma Linda Health. Elaine Darling, the co-CEO and Director of Programs at the Center for Rural Health Development. And Jason Schulis, Director of the Fox Valley Data Exchange. All over the map, different pathways into this work, different levels of experience and investment in this. But with the through line that they all have in common is a commitment to not just focus on vital conditions, but to bring the power of data to this work as well. So let's turn to you, Roxanne, first, and maybe if you can just share a little bit about how you're coming to this, the history that's bringing you into focusing on vital conditions, and the kind of data to action cycle that I know is so important to you and your team.
Great. Thanks, Bobby. Good afternoon, everyone. Again, I'm Roxanne, and I'm with the IP3 team. IP3 stands for Institute for People, Place, and Possibility, and we're a nonprofit that's based in Columbia, Missouri. But since the pandemic, we're all over the nation in different parts of the country. And our organization is really working to create healthy, equitable, sustainable communities, and we're stewards of community commons. We do this primarily through curating resources from the field and sharing them broadly through our public good website, communitycommons.org, and also supporting the field with web-based applications like IP3 Assess to simplify data, reporting, and for needs assessments, data sharing, and data-driven action planning. So we started our work about 15 years ago when data for the public use was really hard to access. We had taglines like data democratization or making public data publicly available. And we were privileged to really be a part of the national community improvement efforts that were really sparked by CDC, Robert Wood Johnson, Kaiser, Kellogg, YUSA, and United Ways, all around the Healthy Communities movements. And through that, we were developing and making data accessible primarily for community needs assessments. And we've continued to grow and learn from our partners and have shifted our approach from just accessing data to actionable data. And on this next slide, you'll see some of the key insights over the years. So these are short, but very impactful for our work. For first, put data in its place. What do we mean by that? It's really looking at not just data-driven decisions, in fact, actually moving away from data-driven, but to data-informed decision-making. We learned that there's a need to really ground truth our data in the community and hear from those that will be affected by these decisions that are being made off of the data. In fact, it's even better to have the authentic voice in the decision-making process. Also, there's data or power. We all knew that from the very beginning, but from a health equity lens and data empowering communities, with that knowledge to drive the transformational change, and then putting that data into context is where the data becomes so much more powerful, and the community can get really into and behind the decisions that are being made. We're just wrapping up a project in Detroit. It's a pilot project. I have to stress the pilot, but it's with funding with CDC Foundation, and we're partnering with the University of Michigan and Wayne State University, and it's called Communities in Context. And this is an approach that is very community engaged and gathering and using local data to improve health. This project really centers in on getting community members' voices, experiences, and perspectives on the data for key decision making, and really considers that broad factors that influence health. The last bullet point that I have on here, and these are not the only learnings that we've learned over the years, but these were the biggest ones and the most relevant to the work that panel today. But catalytic community change stems from the understanding and the shared vision for the future. So actionable data and bridging frameworks like the vital conditions is key to change the conversation and make the data consumable. We have a a phrase sometimes that we use. Sorry, it's called the art and science of either measuring or measuring and data. So what we mean by the art is really that measurement, which includes strategies for engaging underheard voices, valuing the narrative, reaching agreement on meaning and priority with diverse stakeholders and perspectives. And then that science is that measurement, which would include really being open to new frameworks like the vital conditions, measuring well-being through self-report data on thriving, with more localized data to augment all of these frameworks. And we see real value in the vital conditions. So in the next couple of slides, this is how our work and tools really reflect these insights. As I shared earlier, the community assessments is where we started, whether it was a hospital system, public health department, community action agency, whatever. It was what's the data, so what, interpreting and ground truthing that data, and then community engagement, and then to now what, the actions that can be taken and what learnings can be lifted up. The other bubbles around here, you might really be familiar with the community assessment and progress tracking and prioritization. Those might be very familiar, but building the shared language, using reports, engaging the community, all those things are important and are built into the way that we work. And the next slide, we really hope that the data goes beyond the assessment phase. So what is that advocacy and case making? What are the coalitions and networks and data visualizations and ways to use this information beyond the assessment process and to really keep the community informed? If you go to the next slide, which is really showing and highlighting, and since this isn't a live demo, I had to take some screenshots, but at the heart of what we do and the heart of our tool are really the frameworks, with the vital conditions framework being at the core framework, a core framework. What this means to us is that because frameworks are really key to analyzing and presenting data in digestible ways, this means this core framework is available to anybody that we work with out of the box. Now, often we change the data to make it more local or add if there's well-being data that's being collected, but at the heart of it, the vital conditions are central. Our tool will analyze from different sources using Z-score analysis. And so we're comparing apples to apples within each domain so they can be rolled up to C1 score. So you're looking at 7 domains right here. And you're seeing the red and the green. And just know that behind that, and if we were live, we could unpack it, but there are over 75 plus indicators that are hidden behind each one of those. I mean, not each one, but throughout that entire framework screen. The other thing that I wanted to point out is really on the top right, there is a drop down, and one of the other key components with the way that we work is to be able to flip quickly and seamlessly between different frameworks. So we know vital conditions, as great as it is, isn't the only framework out there, nor is it the only framework that will resonate with the audiences. So we try to make it as easy as possible. On the following slide, we have again, very tiny, quick snapshots, but you can see that we unpack the data. This is just showing some of the ways that we have broken out the data. And then on the right, you can even go deeper, see trends. And then down at the very bottom, you'll see how it's connected to the community commons. The next slide, and again, just trying to go through this very quickly, is reporting. And we're unable to show you a report here, but we have a list of reports that you can dive in. And these are ways that our partners have packaged this data, very relevant for their audiences, and being able to really take a look at the data in context with resources. The last slide that I have on here is the community commons. You can go there and explore over, I think we're up to 14,000 different resources categorized with priority populations, with many different ways of segmenting out to find what's happening in the field. And we will be providing you with a lot of different links that you can come and explore this, but thank you so much for your time.
Thank you, Roxanne. That was a terrific tour through more than a decade of learning about what this work takes. And it's a perfect segue to Sequoia Rent next, one of your colleagues who's been doing this on a statewide scale, which is itself impressive to do this not just in a particular community, but to have all the cast of characters across Delaware begin to focus on what are they assessing, and more importantly, where are they placing their priorities for improvement in the years ahead. So, Sequoia, can you tell us a little bit about what your work is doing these days?
Good afternoon. My name is Sequoia Rent, and as Bobby said, I am the Chief of the Bureau of Health Equity at the Delaware Division of Public Health in Delaware, and I'm thankful for being here this afternoon. And I'm going to discuss how we link the vital conditions and data in what we're doing. So the Bureau of Health Equity within the Delaware Division of Public Health aims to eliminate health disparities related to the social determinants or influences of health and the vital conditions for health and well-being in health outcomes. We work in tandem with our internal division partners, sister Delaware Health and Social Services agencies, cousin state agencies, and external partners around the interconnectedness of our related work to multi-solve for Delawareans. Multi-solving is intentionally considering the impacts and gaps of a solution and then working to find solutions to address those as a part of the solution, usually across the vital condition areas and sectors. Our priorities are to intentionally multi-solve and, as I mentioned, to leverage resources and to align efforts so we can maximize our collective impact. As our work relates to the vital conditions and data, we uniquely oversee our state's state health assessment, we call it the SHA, and state health improvement plan, the SHIP. These documents help us track our efforts, not just within our division, but our state as a whole, on our top health indicators and health outcomes, as defined by the data and the voices of Delawareans. Our SHA is a statewide assessment that used the vital conditions of health and well-being framework to shape and align our primary data collection and tracking. We then spoke directly to residents using the vital conditions to shape and frame those conversations. Then we scanned the existing data, the community health needs assessments of our hospitals, and our legislation, and our partnership coalition, and educated and coalesced around the vital conditions, the members of our coalition, and determined our state's top health priorities. All of that informed the creation of our state health improvement plan, the SHIP that I mentioned. Although in previous SHIPs, we did not track our data using the vital conditions framework, we can cross-reference indicators as we move forward, and we can apply the framework in almost any initiative, project, and multi-solve to address it. For instance, we are working with a cross-sector group to end involuntary youth homelessness in Delaware. We, as in Bureau of Health Equity, are a part of this effort because humane housing is a vital condition area linked to health outcomes and a person's well-being, including cardiovascular health, are linked. And article published by the American Heart Association Council on Epidemiology and Prevention outlined research findings strongly linking housing and what the article called pathways for people to cardiovascular health outcomes. People experiencing homelessness, home insecurity, and housing with poor quality and safety to vital condition area components of the thriving natural world and belonging in civic muscle were evidenced in the research, referenced as social determinants of health. It reported the data suggests that compared to the general population, adults experiencing homelessness experience 60 to 70% higher rates of cardiovascular events. Since in Delaware, disparities exist for people experiencing homelessness, the vital conditions offer a framework for us to track that data and work collaboratively across agencies and sectors to tackle upstream causes, both traditional and non-traditional, before they become those prevalences. A 2019 fact sheet from the National Healthcare for the Homeless Council and the National Network to End Family Homelessness stated that youth who've experienced homelessness have a higher likelihood to have higher adverse childhood experience scores, which evidence suggests people with 4 or more ACEs are 2 to 5 times more likely to develop a chronic health condition such as a cardiovascular condition compared to people with no ACEs. Within the framework, we can track data for access to care, access to healthy food, and reliable transportation to said care and food, among other risk factors. Tracking data here can also show if there is no link for some subpopulations, which is also important for us to know. But it doesn't stop there. Our partners are increasing their education, awareness, and use of the vital conditions internally and externally. Internally, the Bureau of Health Equity is integrating the vital conditions framework into our evaluations with partners and our contractors and vendors, encouraging them to build their subject matter expertise and cross-sector alignment. This will increase our data and tracking using the framework. New team members to the Bureau are being educated in the vital conditions and multi-solving as they are onboarded. With ongoing education, its use in multi-solving will become second nature as we look at data trends over time. We are creating a Delaware Health Equity report, integrating the vital conditions framework with another framework and showing how the vital conditions are an evolution of the social determinants or influences of health through the linkages and data-driven action. We introduced the vital conditions to our legislators and integrated them into legislation codifying the Bureau of Health Equity, Office of Minority Health, and Office of Women's Health. We are also spreading this wealth and it's gaining traction in our state. The Delaware anchor hospitals are increasing their awareness of and discussing the vital conditions as they prepare their next round of community health needs assessments. And as a result of our Health Equity Summit last April, more people and organizations are incorporating the framework and multi-solving into their programs and organizations. Delaware kicked off its Cardiovascular Learning Collaborative on October 10th, working to improve the quality of life through the prevention and control of CV and its risk factors. Through 3 work groups, the awareness, availability, and coverage and equity, you could guess which one I'm a member of, and using data, the vital conditions, and the community voice to drive action, this new collaborative will move forward in accomplishing its goals. You can see them there. Advancing health equity and prevention, treatment, and management of CV disease, optimizing health through prevention of chronic diseases, improving response to acute cardiovascular incidents, and support cardiovascular disease management. It was very timely. As a reminder, October is Health Literacy Month, and that is applicable to providers and anyone else who is creating or shaping health materials. I want to thank you again for inviting me, and my information is on the screen. Please feel free to reach out and ask any questions you may have.
Thank you so much, Sequoia. I can't resist asking one quick question, which is, how long have you been working on the vital conditions thing? Like, has this been decades or like how fast have you done this?
Not decades at all. I would say about 2 years.
Oh, incredible. Just the speed at which where you started with the commitment to look at data differently and the degree to which it's become institutionalized. And I love what you said about it being routine and second nature for people to start thinking and acting differently. Lovely. So let's go to the other side of the country, to California. We've got Jasmine to tell us a little bit about what's happening within Loma Linda Health.
Hi, everyone. It's a pleasure to be here with you all today. My name is Jasmine Hutchinson, and I'm the Community Benefit Director for Loma Linda University Health. The Vital Conditions Framework has really been a game changer for us. It's opened our eyes to the interconnectedness of our efforts, inspiring us to dream bigger and act bolder. When it came to data, we started by asking ourselves some tough questions. How are we truly helping our communities thrive? Which of the vital conditions are we addressing and not addressing? How do our policies and programs impact those who are suffering and struggling the most? This honest reflection showed us where we could do more and be better. When it came to our vital conditions journey, we first identified opportunities to integrate the vital conditions into our existing work. The most prominent areas were our community health needs assessment, conducted every 3 years, our grant-making process, which invests in local community-based organizations, and our annual report, our primary communication tool for showcasing our impact. Next, we analyzed our current programs and investments to see how they align with the Vital Conditions framework. After that, we conducted a thorough review of national data sources. The data and measurement resources from IP3 Assess and Community Commons that Roxanne mentioned were an amazing starting point for us as well. It's also crucial to consider the unique local context by examining significant geographic and disparity trends and supplementing with local data and what you have available. So ask yourselves, what are the greatest threats and opportunities in our community and for the populations we serve? For example, in the Inland Empire, California, we have one of the fastest growing populations in the country, making it increasingly difficult for residents to afford housing and access health services. Additionally, the rapid growth of the warehousing and logistics industry in our region is exacerbating what is already one of the worst air quality situations in the country, disproportionately affecting our most vulnerable populations. Applying the Vital Conditions Framework has helped us to identify multi-solvers, those programs or investments that yield benefits across multiple areas. It's also revealed gaps and blind spots that we needed to address while strengthening our cross-sector collaboration by creating this shared language and understanding. So what did we learn from our data journey? First, we acknowledge the need to ask new questions. Our research and data collection tools now focus on all vital conditions and aim to measure the levels of thriving, struggling, and suffering in our community for the first time. Additionally, we've included all sorts of questions to explore barriers to meaningful work and wealth, lifelong learning, and to really assess feelings of belonging as well. Our data journey has helped us identify our multi-solver programs that address multiple vital conditions simultaneously. For example, our Diversity Healthcare Pathways program strengthens several of these conditions all at once. Our grant-making data revealed to us that we had been prioritizing investments in urgent services over the vital conditions. The issue is that we just can't simply provide urgent services to achieve thriving communities. When vital conditions are denied or disrupted, people struggle and suffer, increasing the demand for urgent services and creating this downward spiral. So, we revamped our grant-making criteria to align with the vital conditions. Now, grant applicants must show us how their funding requests will actually strengthen the vital conditions. This subtle shift helps us to prioritize investments that drive real transformative community change. It's also helped us to identify investments that are the biggest multi-solvers. The framework has also been really helpful in identifying where our organization was actually causing harm to the vital conditions. For us, those fell into two primary areas. The first was environmental impact. As a large academic health system, we recognize the need to do more right now to reduce our impact and build resilience to climate change. So we teamed up with leaders from across our hospital and university system to launch a coordinated effort that aims to engage every one of our more than 20,000 employees, students, and faculty to do their part. The second area we focused on was medical debt. Medical debt is a widespread issue affecting 38% of Californians. Patients with medical debt are far more likely to be unstably housed, food insecure, and to delay or forego necessary healthcare and prescriptions than those without medical debt. Medical debt also disproportionately impacts people of color, low-income residents, families with children, and people with chronic health conditions. We decided to tackle this issue in two ways. The first is we launched an internal task force to figure out how we can make it easier for patients to access financial assistance within our own system. The second thing we did was to team up with a national nonprofit and trusted community health workers to launch an innovative program to eliminate medical debt throughout our Inland Empire region of California. With our effort, we're trying to make it easier for low and middle income patients to access the financial assistance programs they're eligible for at more than 50 hospitals in our region. On average, a family of 4 earning less than $125,000 will qualify. By eliminating medical debt, we're not just offering relief, we're paving the way for a healthier, more financially secure and better secure community and better access to healthcare. You can learn more about that program at dollar4.org/LSOL. So how can you integrate vital conditions into your reporting? Along with incorporating new data sources, we decided to use icons to help readers understand how each of our programs and partner investments aligns with the vital conditions framework. Visually integrating the vital conditions has proven to be a powerful tool for communicating our story and connecting our story to the work of others in our region. One of the things that's been most amazing about the vital conditions is how it can create new synergies and cross-sector collaboration. We're lucky enough to have a growing regional network that's allowed us to make new partnerships and align our work around the same North Star. The ultimate goal of our work together is all people and places thriving, no exceptions. Thank you.
Jasmine, you were not kidding about dreaming bigger and acting more boldly. What an impressive story. That again, the through line here is beneath the data is a kind of passion to be able to work differently, to be able to pursue multiple goals at once and to look for those multi-solvers that make sure that they're going to connect. Lovely. So let's go to Elaine in West Virginia. And one of the nice things that we're also hearing throughout all these talks is the ways in which this is not a disease body part population framework. It's a way to look at people and place. And I'm wondering how you and your colleagues in West Virginia have been using this to take a fresh look at what's possible in West Virginia.
Good afternoon. Thank you for inviting me to be part of this panel. I'm delighted to be here with you today. As Bobby mentioned, I'm with the Center for Rural Health Development, which is a nonprofit organization located in Putnam County, West Virginia, but that serves the entire state. We have a twofold mission to improve the health of West Virginians and to strengthen West Virginia's healthcare delivery system, especially in rural and underserved communities. We have several programs at the Center for Rural Health Development that focus on one or the other aspect of our mission. The program that I'm going to talk with you about today is our newest program, Wild, Wonderful, and Healthy West Virginia. We developed this program in 2017, 2018 because we were looking at America's health rankings and noticed that West Virginia has been in the bottom 10 of all the states every year since 1990. Sometimes we bounce around a bit within that bottom 10, but we've never made it out of the bottom 10. And although we have strong programs at the Center for Rural Health Development, we felt that we needed to develop a new program that targeted the root causes of many of our health issues throughout the state. So we developed Wild, Wonderful, and Healthy West Virginia to provide support for local collaborative partnerships to develop community health improvement plans that create long-term sustainable changes to improve the overall health of communities and promote economic prosperity. This is a snapshot of the community health improvement planning process that we use. We begin the process with visioning and stakeholder engagement. In that phase, we work with communities to define what their communities are. Some decide to focus on an entire county, others focus on a city or town, and some community teams focus on a neighborhood. But it's up to them to make their decision on what is truly the community that they're focusing their community health improvement planning work on. At the same time, we work to develop cross-sector community teams, and I'll speak in a little bit more depth about that in just a moment. Those teams then conduct the community health needs assessment, and as part of this phase, they begin utilizing the vital conditions framework to consider the health and well-being of their communities, and they look at the data within each of those conditions. They also use this time to conduct community listening sessions, surveys, and or community forums to gather additional information about the health issues within the community and to inform the development of the community health improvement plan. The Community Health Improvement Plan is a 3 to 5 year plan that describes the community's goals and strategies, including policy, systems, and environmental changes, to improve the vital conditions within their community. Once they've developed their Community Health Improvement Plan, they develop action plans, which are a 12 to 18-month plan of the steps that they'll take over the next year in order to work towards meeting those long-term goals identified in their CHIP. I previously mentioned the development of cross-sector teams at the start of the community health improvement planning process. This is an illustration of the sectors that are typically represented in these cross-sector community health improvement teams. While hospitals and health departments, et cetera, typically conduct community health needs assessments and community health improvement plans, it's vital that to achieve the most success in advancing the goals within the subsequent CHIPs, that a variety of sectors are engaged in the community health needs assessment and the community health improvement planning process. One group that I would especially like to highlight and emphasize the importance of engagement with are individuals with lived experience. They have unique experience, expertise, and in-depth knowledge about the specific health issue being faced. And so we feel it's vital for them to be engaged throughout the entire process. While we work with the community teams to conduct community health needs assessments and then develop the community health improvement plan, we began pulling data from a dashboard that was created for us by IP3 Assess, which breaks out the health and well-being data by vital condition. Here you can see a screenshot from our website, but each of those vital conditions then break down further into subsequent data related to each condition. They've also provided data for all of the counties in West Virginia and for the communities that have requested it, including some neighborhood data and city or town data. So this has been a very helpful resource for us as a starting point for developing the community health needs assessment. We frequently augment and pull in additional data depending on the vital condition that the community wants to focus on. And then again, we typically use community surveys, interviews, listening sessions, and/or community forums to augment this information and to be able to use it to inform the development of the community health improvement plan. We are currently working with 8 communities throughout West Virginia through our Wild, Wonderful, and Healthy West Virginia program. Most of these communities have been engaged in this program for several years, although we do have one community that just began this program. Here you can see the vital conditions that each of the communities are focusing on. So some focus on safe and affordable housing, others focus on meaningful work and wealth, and some focus on basic needs. Some focus on more than one vital condition as well. And typically they'll start with one vital condition, and then when they begin to develop a new CHIP, they'll expand and bring in another vital condition to focus on as well. Some of these communities have been engaged for several years and are now on their second community health improvement plan. As they work to develop their next community health improvement plan, they review the vital condition data to evaluate their progress to date and then develop their next CHIP and action plans. Thank you.
Marvelous. Thank you so much, Elaine. I'm just so struck by the idea of the learning journey into this work. The starting places, it's hard to predict where it's going to go when you start getting into it. And the statewide coverage that you're describing is really thrilling. So let's turn to Jason Schulist. I've been to the Fox Valley. I've seen the energy of hundreds of contributors there. And there is something new under the sun in Fox Valley, right? The formation of a place-based wide-angle data exchange that many players across the region are now committed to the idea of data exchange. And so I understand the vital conditions figures prominently in that. So can you tell us a little bit about that work?
Yes, I'm excited. And thank you, Bobby, for inviting us to share some of our work. We are humbled that we are part of this amazing group that I just heard about right before me. I'm stunned by all the great work that's going on. So when we started our work, the seeds of the Fox Valley Data Exchange really began with something called Imagine Fox Cities. And what this was a shared visioning project for 19 cities and towns in our local community up here in northeast Wisconsin. As part of the process, what we did is we convened our 88 community conversations in our community and administered a well-being survey, kind of very similar to the happiness report, the Cantrell ladder that Jasmine talked about at Loma Linda. And really, we did this to determine how the Fox Cities community was thriving, struggling, and suffering. As a side note, if you look at the Imagine Fox Cities website here, You can see on this page that one of the opportunities that emerged was belonging, and that popped up both in our qualitative and our quantitative analysis. So while we collected this data both in 2019 and 2021 as primary data, you can kind of see the amount of surveys that we got out of our 250,000 person community at the time. We noticed that we didn't really have an easy way to understand the overall data in our community. So we decided to canvass the Tri-County area, of which this Fox City is, so we call it the Fox Valley, how we could look at the Tri-County area and learn what data needs really our community had. And we found a few things. One, it was really hard to find data. You could scrounge around and look for it. If you're doing one of these chip or chop plans, you might hire somebody to go and find the data in various data sources. So we wanted to kind of clean that up and make it easy. We also found that there were many ways to measure the same thing. So we thought if we could improve alignment and get everybody together, we could kind of choose the metrics and the way to measure those metrics so that we have a consistent narrative across our community. We also expanded beyond the 19 Fox cities to this entire Tri-County region. So we went from about 250,000 people to about 400,000 people. And we wanted to improve our well-being from our past learning. So we could see our thriving, our struggling, and our suffering scores. We wanted to get better. And we knew that using the vital condition framework and using that mindset can really help us versus using a deficit mindset. So that really led to the creation of a nonprofit, the Fox Valley Data Exchange. We wanted to make it a nonprofit so that it was agnostic to any one funder. We had previously done some work in this area through our community foundation and our United Way, but we wanted to make sure that we were much more integrative. And so we wanted to make our data easy to find and transparent for the community. So this totally free resource, and you can go out at vitaldata.fvdex.org and check it out anytime you want. It helps our 7 stakeholder groups. So we have nonprofits, foundations, business, healthcare, public health, education, and faith communities that are working together across these 3 counties to make data-informed decisions on where they can invest in the vital conditions. We use the vital conditions framework as our framework to think through the work. We do that because we want to shift the mental models within our community, move from deficit thinking to kind of a growth thinking. And similar to our Delaware friends, enables our stakeholders to work together cross-sector and across the vital conditions so that we can multi-solve our biggest issues. This is just an example of our easy and accessible data platform. So as you can see, on the left-hand side, we break our data down along the vital conditions, and we look at this data geographically. Now, heart disease mortality may not be on the the high on the vital condition framework. It's something that's a little bit more on the lagging indicator side. But with one click, I can move from a geographic base to a trend chart of any of the 100 plus data points that we have to help describe our vital conditions. So our 7 stakeholder groups across the 3 counties are really working together to determine what to put under each vital condition. And as we go through that dialogue, we start seeing us working upstream versus downstream in the things that we are measuring. Thanks to the IP3 group that does a really great job curating a set of metrics around the vital conditions. Finally, to determine what we're measuring, we're also integrating local data sources into our website. So we have things like 211 data or mental health primary survey data or our youth behavioral risk survey. All of these are planned for integration into the site so people will have easy accessibility to look at those problems that they want to work on. So our current Tri-County region is coming together to create a unified CHNA chip plan between public health and healthcare, kind of similar to how West Virginia is engaging in their state kind of with the vital conditions. So we're using the vital conditions framework to help really create that community health needs assessment process, and then also how we invest in our community health improvement plan. The Fox Valley Data Exchange has been working alongside this effort to really assist in providing and maintaining data for the community. Many times we'd have that plan, and then then there might be every year or so there might be an update. There might not be. We have 7 of those plans right now, so we're going to try to get down to 1, and we'll be able to keep that data refreshed so people can use it and see how we're making progress in our community. We also plan to kick off an annual well-being survey starting in 2025 for our Tri-County area so that we can keep a pulse on our well-being and really ensure that the stewardship and the effective resource allocation along our vital conditions happens continuously as we continue to grow and evolve. So I appreciate the time that we've been given, and thank you very much for listening to how we're progressing.
Thank you, Jason, and thank you all for, in a very short amount of time, giving us a really rich portrait of what this work looks like. I've heard so many similarities and some differences in terms of how you're situating this into your place, into the organizations that are most passionate about this. And that's maybe one place that we can go in our discussion now is a little bit more sort of personal stories about what have you seen about the people who are drawn into this work, the kinds of like openings or invitation that they're experiencing when you're starting to maybe flip the script on what a conventional analysis or a conventional data report looks like. You're all innovating off of a form that has become commonplace. So I'm wondering if you can share stories about the people who are drawn into this and what kind of energy they're experiencing when you start talking about vital conditions, when you start talking about the people and the places that we love and what it takes to unlock their full potential. So we could do this in any order. If any of you have a story in mind, or maybe we'll go back to Sequoia, because that photo of the team coming together and institutionalizing something that didn't exist before, but behind the scenes is a different way of working. So can you share just a little bit about what the energy in that room was like? And I'll leave it at that.
Sure. So coming up to that, we had several discussions, right, about the language in that particular bill. And it started out with the more, social determinants influence of health. And we had to, talk about what the vital conditions were, how they were in evolution, why we wanted to talk about the interconnectedness of the vital conditions, what they meant for the community, how they were less individualistic, and how they work together. And there were iterations of that bill, and that's why I wanted to share it, because it's kind of monumental, right? The Bureau of Health Equity in Delaware has existed for more than 10 years, but now it's in law. Like, we exist in law, and the vital conditions are a part of that bill. And it not only codified the Bureau of Health Equity, but also the Office of Minority Health, which has also existed for quite some time here, and the Office of Women's Health, which had existed, but is now, all three exist. And we have movement there and raised awareness about the vital conditions. And even though it existed there were people in the room, some other legislators, and our governor, obviously, in that picture, who are learning and coming together, because aligning a message across the state about how we do our work, not just at state agencies, but in the community, how we track our data, how we look at trends over time, how we thrive, how we build Delaware together as a community is important. And the vital conditions are helping us do that. The framework.
Love it. Love it. I'm wondering about others here. Sequoia mentioned a thing here that, there's comfort in the conversation about social determinants now. And so there can be some reluctance to change the vocabulary. There has to be good reasons for that. And I'm seeing some heads nod on that one. How have you gone through the sort of inertia or growing pains about introducing a different vocabulary with people who might be very eager to stick to the script? I'm seeing Jasmine. You're nodding on that one. What does that look like for you guys?
Yeah, I think especially I think about the hospital context, and there's so many folks who really wrap their minds around the social determinants of health, and it's been such a big part of the script for a while now. There's still a place for the social determinants of health, especially in healthcare. We are now, really at the individual level. We do need to know if folks are kind of falling behind and they need a hand up and what that looks like, right? So our hospitals, all the hospitals now across the country are required to be measuring that. So on the individual basis. But with that, I would say, I have presented at a number of different, about the vital conditions in a number of different spaces, our health equity task force, social determinants of health task force, all these different groups. And I think folks also see that it helps to bring other sectors together. And that's the most exciting thing, I think, for me, because we actually went through a whole process of redoing our vision statement a few years back, and realizing, one of the things I realized was how many different groups out there in our region had the word thriving or some synonym of thriving in their vision statement, and just realizing like we're all aligned on this. And so being able to recognize that our partners in the education system and in the housing authority and all these different places, like we really just all want the same thing. I think that's really important. And especially, in the world of health, I have very often found myself just only surrounded by people working on health, right? And it's pretty common, I think, to be in your own silo. And so what the Vital Conditions does is it helps us be able to have those conversations with other sectors and recognize that we're all working towards the same, thriving communities.
That's lovely. It makes well, we'll go to Jason one second, but it makes me curious about Elaine. I'm so intrigued by the way you've titled Wild, Wonderful, Healthy West Virginia. Is that serving as an attractor for very different people to show up and say, what's my part in this?
Yes, so Wild, Wonderful, and Healthy West Virginia is actually taken from our state's tagline that we had for a number of years, which was just Wild and Wonderful West Virginia. And so we added the and healthy part to it because we wanted to speak it into existence. We want that to be our future. And so that's how we came up with the name Wild, Wonderful, and Healthy West Virginia. And we've worked with the communities to do a lot of branding specific to make Wild, Wonderful, and Healthy Logan County or Clay County or what have you. And so that they're using that same message and speaking it into existence within their communities as well. But I also want to go back to your previous question on the vital conditions and that switch from social determinants of health to vital conditions. I think that change in terminology, I think, has been very helpful for engaging folks that are not in healthcare and public health in this work. And I think for those who are working in healthcare and public health, it helps them to understand that this is not exactly the same work that they're doing when they're measuring social determinants of health within their patient population. So I think it's really been a way to strengthen the engagement through both of those groups, the healthcare public health groups and the non-healthcare public health sectors as well.
Love it. And Jason, I'm guessing, you laid out quite an array of stakeholders to the data exchange, but what's on your mind here?
Yeah, when you think of some of this work, sometimes you start to think of health, and I know we're at a health conference, so it makes sense too. And it was just an interesting story. So the Habitat for Humanity in our area, they do a thing called Rock the Block. And so Rock the Block pretty much gets a group of volunteers together to go help out in the community, clean up people's outside of their houses, do small repairs, and so on and so forth. But from a multi-solver perspective, it was really interesting because they went onto the data exchange and they looked for different sources of data. So they first went into the usual suspect, humane housing, right? And they looked for people who were severely rent burdened or housing cost burdened to think about where to maybe focus their next Rock the Block. But then they went into meaningful work and wealth, kind of tried to look at a little bit of the poverty side, but ultimately they landed in the belonging and civic muscle area, looking at the social vulnerability index and looking at seniors living alone. So as they thought about their strategy of cleaning up a neighborhood to make it feel better and look at it outside, they're also thinking about the social connectedness nature of interacting with people in the community. So they were able to pinpoint a specific census tract that they wanted to work in based on using the data in a multi-solver kind of way to get to the point of not only helping from a housing perspective, but then also helping from a belonging and civic muscle perspective.
Sequoia, it looks like you have feelings about that one.
I do. It's what I mentioned earlier. It's the interconnectedness of all of them. And that's one of the things when I talk about the vital conditions that people hear, it's that nothing that we do stands alone. That's why when we talk about eliminating youth homelessness here, we're talking not just about humane housing, we're talking about a thriving natural world, we're talking about their basic needs for health and safety. We're talking about their education, the McKinney-Vento. We're talking about all of it. That's why I think the vital conditions has gained so much traction in the short amount of time that we've been using it.
Yeah. There's another piece of your story, Jason, which is, we've all sort of, sort of acknowledged the aspiration for equity and racial justice, but what does it mean to really identify those that have the most to gain and channel resources first among those so that, we're not sort of casting resources evenly and equitably, even in, consistently, as opposed to identifying those that are poised to make a great stride forward. And that's a little bit of what I heard in your story. It's wonderful. Roxanne, I'm thinking about other kinds of data here, the signals that tell us that, what kind of resources are people looking for? And you have a remarkable asset in looking over the shoulders of those that are using the community commons, this treasure trove of free resources. And are you seeing, and I can't think of any entity in the country that has made so many free resources available and organizing them around vital conditions, organizing them around the questions that that colleagues are curious about. So what are you seeing in trends around what people are looking for in the commons?
Thanks, Bobby. Yes, as I was thinking about all the different stories from the field itself, was trying to think of the times that we were able to maybe be in community. We were out in the Inland Empire. Some of our team was out in the Fox Valley. And so thank you for the entree into what we're seeing from a commons perspective, because I didn't get enough time to really talk about the commons. Some of the things, and one of the things that we have seen quite a bit, and this stems from our early days of being more of a data provider or data access, as I was talking about. So consistently, our maps and data channel is one that people go to. Either they remember that that's where it's from, or that's what we had most to offer at one point in time. But from that standpoint, we've been able to take that interest in still going to maps and data. And I think that there is a link that I've provided that hopefully it can be used and shared with the audience, but it's the Maps and Data channel on Community Commons. And that's where we're really lifting up all sorts of different either mapping tools or other tools that have been created by others in that channel itself. In addition to that, we've tried to data equity is another key place that people take a look at. And then quite honestly, vital conditions is the other top three that people are searching for on the common. So however the word's getting out there, the appetite is definitely there on the commons itself. And again, I'll try to give the right links so that you can go straight to these components. Or the commons was actually supposed to be a discovery platform. So you might be going there to look for something. So you might be going there to find the mapping tools, but what you'll find within that channel is not just the tools themselves, but all of the wealth of other resources created from the field. And that was one of the things with the commons. You might have to click twice, and that's because we want people to go back to the original source of those tools so that we are increasing the traffic back to the original group that put that either tool, resource, survey, what have you together. So really maps and data, thriving, and equity, data equity too.
This is another one of those similarities I'm hearing in all of your stories is a closing the distance between a measure, an indicator, and the things that one could do to move it, to change it. So there's so much, it's like really hard to get insight into what other counterparts are doing in other places. And if we could, kind of hold that aspiration that the signals that come through our data systems are really an invitation to a new kind of action. And that's what I'm hearing in much of your work. We only have a few more minutes, and maybe we can end with a round of discussion about what you're wishing for next. You've all set up, sort of a platform to prompt people into new kinds of action. Well, certainly to inform them about, sort of the state of play at the moment, but to prompt people into new action. And if I'm hearing it right, you've set up systems that will detect change over time as well, right? You'll be able to celebrate progress or spotlight those areas that need greater attention that have maybe, being neglected. And so maybe share with us your wish for what you think these data systems, these data platforms can do, let's say, in the decade ahead. And maybe we'll go in reverse order. Jason, why don't we start with you?
Yes, thank you. There's three things that I think about, and I described a little bit briefly before. One is we want to get into a cadence of an annual well-being survey. If we can start to understand how people are doing and whether we're seeing changes in well-being, as well as we do about 14 different questions, including open-ended questions. That gives us a chance to really look from an open-ended perspective where we're seeing some trends. Recently, we did some neurolinguistic programming with our old survey to try to start to find out where and what was bubbling up that wasn't in the numbers. So getting that qualitative side going. The second thing is really, I call it scaffolding for experimentation. So if we can create a system where people can test things and we can learn the reaction of what those tests are, that gives us a chance to create a platform that others can then use and tie into locally, so we can start to know what's really moving the needle and what isn't. We're in a complex adaptive world, and it's not just easy cause and effect. So by starting to understand that is going to be important. And then finally, the continual integration of local data. So one, if we're doing an annual survey, that makes it really easy to do a chip chop plan that can just integrate that right into the thing without having to do another survey. So can we start to continue to just align things and create more and more understanding to paint pictures of where we need to invest in the vital conditions?
Great. Elaine, what do you see when you look ahead?
Well, the work that we're doing with the community teams is a cyclical process. So we work to develop the community health needs assessment, the CHIP, the action plans, and then we continue to then start all over again, developing the action plan for the next year, and then eventually get back to redoing the CHIPs and creating new ones for subsequent years. So as we go through that process, we continue to pull the data and use it to evaluate our progress and achieving the goals that we've set out in our CHIP. And so we continue to go back to that data and look at it. And then I, of course, pull additional data or conduct additional surveys and focus groups to be able to then inform the next round of that planning process.
Marvelous. Let's see, Jasmine.
So a couple of things too. I'd love to see more organizations in our region integrating the vital conditions into their own reporting, because I think it really helps everybody else understand, how are you contributing to these, and how does that connect with what I'm doing? So the ones that have done it, it's been really helpful. Data sharing, I think, some folks have touched on it already, but I think that's huge. We find often our community can be over surveyed, shall we say, and there's just a huge kind of burden with the surveys. So the more we can kind of share that data across, and also the findings from it, and have a place to do that, I think is going to really help both the community and make community and our own organizations as well. And then I would also love to see like maybe alignment around, say, one priority or one vital condition, something that, you know, we're all working towards, but we all have some kind of a role. So maybe it's, it's high school graduation rates, or just something a little bit more specific, but something that's going to have an impact on all these different areas, and have, folks really think about like, what are you doing in that space? How can we contribute to this? Because I've seen this done really effectively at Seattle, King County in Washington State. They have really, got on all their government offices to align around a particular priority, and figure out how to do that. In their case, at the time I was there, it was Medi-Cal enrollment, say, but people got so creative across those government agencies around what they could do to help promote that. So,
Marvelous. Sequoia.
So I'd like to echo something that Jason and Elaine both said, because our SHIP and SHA process are cyclical, right? So I'd like to see sectors come together that wouldn't expect to be together, like Department of Transportation and Department of Education, from different vital condition areas, talking about data that they don't think is aligned, but really is, because we all are trying to have positive health outcomes for our citizens in all of our states and all of our areas, right? I'd also like to see us increase belonging and civic muscle, because I think that that's the one that drives all the rest. I think it's why it's at the center, even though I didn't create the model. And I'd like to see, for Delaware anyway, our SHA-SHIP Partnership Coalition, which is made up mostly right now of organizational stakeholders, be filled with just community members who are exercising their voice in what they see, so that we are really literally acting out the thriving together theater, so that they're literally deciding what our trade-offs will be.
Lovely. Roxanne.
So from a national perspective, I think that when I look to the future, there are several things that I would love to see. We've talked, maybe not on this call here, but about the thriving ethos and the infrastructure that's needed to help the thriving ethos. So it would be wonderful to have things even as simple as the online forums. And I know that sounds dated, but there's different ways to do things now where people such as the people on this call can come together and share the ideas on an ongoing basis, not just on a webinar. Infrastructure around maybe completely free for at least the vital conditions nationwide tool would be wonderful, to be able to share on an ongoing basis. And then thirdly, just Bobby and Monty and others can't be at every different place. So what is a curriculum, or even just a way of bringing together a set of videos and things to help communities who are just trying to dip their toe into it to get started? So there's a hunger for how do you get started in this work? So that's what I would love to see from a national perspective to help the rest of the country.
That's lovely. And I'll just end from my perspective that there is a frontier of measurement that I think about it in three, sort of three phases. We can measure what's happening with individuals, their well-being, their thriving, struggling, suffering. We could then look at the world around people and say, how well are we establishing vital conditions, doing that equitably, leaving nobody out? And then there's the question about who's stepping into this work. Are we joining with each other, tightening those connections, like building that rising movement of players? And, the colleagues across the National Forum here are an audience of incredibly influential people where the frontiers of this work could rise. And I see one sign already that in the curriculum or the design of the annual conference, which is now in its 20-something year, right? There's increasing attention to these kinds of themes, and just creating space for our dialogue today and the many panels that have gone before is itself a signal of innovating on the things that most matter in this work. So thank you to the National Forum, and thank you to all of you for not just what you've done today, sharing your perspective, but the work you do every day.
Well, thanks right back at you, Bobby Milstein, and all the panel members. My gosh, thank you for sharing such powerful examples of how data-informed approaches can fuel change and create sustainable impact in our communities. I found that this discussion highlighted how essential it is to not only collect and analyze data, but to use it in ways that strengthen the vital conditions for health and well-being. If you have questions for our panel members, please submit them now. We already have some, which is great. I want to note that Sequoia Rent had to depart just a second ago. So her colleague, Dr. Yanda Cuffey, an assistant professor of epidemiology at the University of Delaware, has joined us. So welcome, Dr. Cuffey. You're on mute, by the way. And I'll begin by saying that Roxanne's point about putting data in its place, using data-informed decision-making rather than data-driven, resonated with me, and I'm updating my lexicon accordingly. So thank you, Roxanne. We have, as I said, several questions, the first of which comes from Ray Bridgewater, who asks, as you're using technology in your health outreach, how are you using medical mobile units to physically reach your most vulnerable population, whether it's in a rural, urban, or mountainous region? Elaine, since he said mountainous, let's begin with you.
Well, we are very mountainous here in West Virginia. However, I would say our focus with the community health improvement plans is to go upstream. So we don't necessarily, through the Wild, Wonderful, and Healthy West Virginia program, we don't necessarily provide direct medical services. We look at the policy systems and environmental changes and integrate those into our community health improvement plans. However, I will say there are many groups in West Virginia that are using mobile medical units, and we definitely saw an increase in the number of them being used during COVID, and many of those have continued since the pandemic. So they are very frequently used in our state.
Very good. Does any other panel member have a different experience or a different perspective? All right. Ray, thanks for the question. Elaine, thanks for the answer. That takes us to our next question, which is from Caitlin Hodge, who asks, are you all using these I just said y'all, she said you all. Are you all using these frameworks in place of MAP 2.0 for health assessments and improvement plans, or in combination, using the two together, or taking another approach?
Well, I'll just say by way of context that I remember the earlier generations of MAP when it was really centered around the role of the health department, and MAP itself was an evolution to put the health department into, an ecosystem of other players in the same sandbox. And so the structure of the MAP inquiry was appropriately broad and curious about, what are the forces of change and what are the community assets and so forth. This vital conditions work in some ways is like yet another evolution. I don't think it's a either or. It's about deepening the inquiry about what's going on in this place, what are the assets and current status that we could work with, and it gets even more precise about celebrating those places where progress has been made and securing it, and really concentrating on those places that have room to improve still. So I don't know that there are too many local governmental health departments that have formally integrated the two, but I think this is one of the frontiers. And Jason, the Tri-County assessment happening in Fox Valley is, it's 3 health departments, multiple hospitals doing for them the first time a joint assessment. So it's a good question to those health directors, how does this combine with MAP?
Yeah,
I'd just say in general, it's a great question.
we have 5 public health areas because we have 2 cities,
Okay.
3 counties, and then we have another 4 hospital systems. And we're trying to work on this together. We are using the MAP 2.0 process to do that. I'll call it MAP 2.0 light, only because we're trying to get into a cadence where we're all on the same time frame, which will be a 3-year time frame. But what we've done is from a secondary data collection, we're aligning them all to the vital conditions. So we're looking at all of our information in the vital conditions called framework. We are also taking the primary data collection side of doing some well-being surveys here in the next couple months to kind of at least get an understanding of where we are since the last time we took a survey, just in our 19 communities, not in all 3 counties. So, so we're using both of those as part of our process of collecting information so that we can do a data walk that'll then drive the improvement plan.
And I can jump in here as well from the Delaware State Health Improvement Plan that we've been working on over the past year. We started as Sequoia said with the SHA. Now we've evolved into working on the SHIP. And as we thought about MAP 2.0 and we thought about the vital conditions, we heavily use the vital condition as a guiding framework for our SHA. And we've continued that into our State Health Improvement Plan. And so we've actually have a section in our SHIP where we actually talk about the similarities and the overlap between MAP and the vital conditions and how we're using both of them as a guiding framework for what we're doing across the state.
All right, thanks. Anybody else? Well, this next question, wow, it really goes to the heart of one of the real challenges that I think all of us who work in public health and in population health improvement face as a big practical question. It's posed by Justin Wong, and he says the concept of determining which communities need the support first ties back to the notion that contributing to this work only makes the pie richer. I've always loved that sentiment, but I think part of what fuels the zero-sum game mentality is the amount of funding that exists for different initiatives. I'm sure this rings true for any organization looking for funds to implement different aspects of their work. That is to say, if we don't get this funding, then it legitimately restricts what we can do. Have there been efforts to look at how funding sources or entities contribute to the creation of the silos that separate out the different social determinants? Or really, if calls for applications were framed around vital conditions, would that yield more applications that engage more cross-cutting community building solutions? I'd like to begin with Roxanne, given your sort of macro level perspective, and then see what other perspectives different panel members have.
Yeah. To take in. So I would think that sorry, I'm trying to formulate what I would think would be helpful. I think that there is more definitely around the vital conditions. I think people would be able to see more of the multi-solving possibilities. I do think that there are things within the thriving ethos such as multi-solving, vital conditions, and the stewardship concepts that are very important to maybe yield more cross-cutting community building solutions. I think that there are, and I thought I heard on some of the panels of trying to have funding sources tied. I think, Jasmine, you talked specifically about some of the grants being made, being tied to the vital conditions. But so I'm thinking about it more from a national, but also broader than just the vital conditions, but a lot of what else goes into the ethos of thriving. I don't know if that was helpful.
I'm happy to jump in too. I think that I would say that we're early in our journey. Our region is early in the journey. We do have, one of the large grant making organizations in our region is fully on board with the vital conditions. So I see, there's going to be some shifts. I think more of us are starting to think like that too. And there is something really beautiful that happens when it's not just a request for how to address one of them, right? But really to think about the multi-silver and thinking about who else can you partner with, I think is always a really important question for that, to make sure that folks are thinking outside of their sector too, because that's where I think a lot of the magic can happen, is when we sort of break down some of those silos as well.
All right. Yeah, Jason.
Yeah, just yesterday, I was working with our local Goodwill on behalf of one of our foundations to talk about looking at a geographic perspective of addressing, in our case, basic needs or poverty. We went through our metrics. We found a specific census tract that we wanted to focus on, and then we went through our 100 metrics across all the vital conditions to start to look at what is significantly changing in this one census tract as compared to the rest of the area. We ended up getting down to, besides the core poverty rates that were going up in this one census tract, we saw our vulnerability index became one of the really key areas that could show this difference, and it wasn't just driven by the poverty numbers because it's an index. And so we're digging in, and we see that in this case, that in 5 years, this area went from like a 17% vulnerability to a 70%. And in 2 years, it went from 30 to 70. So what's interesting is that we can see in 2 years how a metric may change significantly. We're going to do more investigation with lived experience and so on to dig into that. But it was interesting that we went through all the different areas to start saying, this is not a transportation problem. This is not just a work and wealth problem, but that we could see across there many different variables that are changing in a very specific community. And so we're planning to do an investment in that community more as a multi-solver investment, not as a point-in-place investment.
Yeah, I'll just add really quickly. I put two responses to this question in the Q&A. Overcoming the default mindsets about how resources flow is one of the biggest challenges, but it's also one of the biggest opportunities. And what we found is that it really helps when the full well-being portfolio is built at a regional level. So every organization is typically used to the things that they put money out into the world to do, but rarely does anybody ask, how do all of the resources that touch a given population or a given community, a place, how does that add up into the net investments in a region? So we use the well-being portfolio as literally a way of aggregating together the assets that are touching a defined population, and then gather the people who hold the purse strings around those assets to ask, okay, what you're investing in, but the net result, is this what we want together as, for the prospects of this community? And over again, when we do these portfolio negotiations locally, people begin to recognize that, everybody funding their piece is not adding up into even a plausible agenda for system change. It's really a way of squandering a lot of resources into small, discrete programs and projects, rather than investing and reinvesting in a strategic, kind of path toward a different future. It doesn't take very much for people to discover that. And we've seen real progress in very quick amount of time, where people start making different kinds of funding agreements around this work. And so I put in links to some of what we're seeing by people who do that work.
And Bobby, what role does data play in changing that dynamic that you just described?
Yeah, I mean, it's twofold. One is, it's really important that people understand and have a common sort of view of the life experiences of people in the population. Where are we, on on a scale from the, sort of fully established vital conditions to none at all, right? How do those vary? So real information about the current state of the world, the aspirations are obviously established very high. And so then the question is, how should we be investing? And that's, people run into a big vacuum because it's not clear we're tracking investment information together. You really need to start, sharing a different kind of dialogue with other people who are making investments. And the abundance of what those assets are is often invisible to a lot of people because they're only looking at their own contribution. The minute you start aggregating it at a population level, what is invisible about the investment flows starts to become more visible and even modifiable. And that's where you start to see, real assets flowing into efforts around belonging civic muscle.
All right. Very important question. So much depends on resources. Steve Sidney, the Chief Scientific Advisor for the National Forum, asks a question about how do you integrate vital conditions with conventional measures of cardiovascular health, such as life's essential 8. So looking, for example, at physical activity, smoking status, sleep status, some of those factors that are risk factors for poor cardiovascular health. I'm pretty sure I know one word that's going to come up here quickly, but I'll hold it to see.
Yeah, and I'm wondering if you might want to start the conversation around this one. I know you think about this interface a lot.
I do. Thank you so much for tipping that to me, Bobby. So a part of our work, as we think about our work with the Delaware SHIP, we have created our objectives, so our overall goals and things that we'd like to achieve across the state. So really, how are we going to advance health and wellness across the state of Delaware? And we have a number of goals and objectives that we're focused on. And so while we didn't formally link that to the simple 8, we do cover each of those things. We think about reductions in tobacco and nicotine. We are looking at blood pressure. We're looking at HbA1c levels as well. And we're also looking at things like how do we engage our community in healthy sleep behaviors, but also in physical activity. And so as we have these milestones, we're working with our community members, our coalition members. We're talking to them about the initiatives that are already taking place across the state, but where there might be areas of opportunity that we can build from with working with DPH and working with the University of Delaware. Are there other ways that we can continue to advance the simple 8 across our state as well and factor in these very important health factors for improving cardiovascular disease in our community?
Very good. Does anybody have anything to add?
I mean, just one little simple thing, which is a measure like, tobacco use can be treated as an individual risk factor, or it could be treated as a sign about the extent to which we have, as a society, set up a condition where people can be free from addiction. And so, you can look at the social history of tobacco to see, it was actively promoted and then it became recognized as a lethal threat. The norms started to change, and we are still yet to accomplish the ambition of becoming a smoke-free society. And we're paying a heavy toll because of that. So, it really depends on your interpretation. And Jason, I think you talked about the metrics, like heart disease risk factor metrics are in your Fox Valley Data Exchange. The question is, how are people interpreting those metrics as a mandate to change structural conditions and exposure to risk, versus are they interpreted as, oh, somebody needs, a smoking cessation quit class or something? Those are two different responses to the exact same data.
And we've been thinking and starting to discern around, like, I guess this concept of it's not exactly leading and lagging indicators, but kind of driving indicators, where one is an indication of something else is an indication of something else. And so we're just starting to get into that space, and we are currently put everything under the vital conditions, but we're actually going to add another little area for, I guess, non-vital conditions, but important information around our community.
So as long as we're getting creative about this, right? If you're looking at one of those risk factors, whatever one they are, let's just take tobacco for the moment. The tobacco rate should prompt us very quickly to ask, how much are we spending on tobacco, comprehensive tobacco control in our community? The CDC publishes benchmarks for investment, and I don't know that that linkage is nearly as frequently as it ought to be.
Well, thank you, Jason and Bobby. Those will have to be the last words. We have reached the end of our time for Q&A. Jasmine, Elaine, Yanda, Roxanne, Jason, thank you all very much. Terrific panel. I think a lot of people, including me, gained a lot of insight into how to make more valuable use of data and how to have data inform good decisions as we seek to strengthen the vital conditions. So thank you all very much. The National Forum is grateful for your contributions today and appreciates the work that you're doing. We're now going to shift to our next segment, which is National Forum members and stakeholders sharing your experiences. Bobby is sticking with me. Thank you, Dr. Milstein. This is going to be an opportunity to hear directly from meeting participants who are their thoughts live on how the vital conditions framework informs, facilitates, and resonates with their work and initiatives. We have several participants who volunteered to share, and we're going to begin with Gladys Ikaza Hunt, who is the Health Equity Liaison at the University of Tennessee Health Science Center. Gladys.
Thank you so much for giving me this opportunity. I was told I had like 60 seconds to share, so I'm going to make it really quick.
We'll give you 90.
Okay, well, thank you. So there's been a few things that we have been able to implement and been very successful recently, and so I wanted to share those. One is the implementation of somebody said earlier this morning about the neighborhood, that health happens in the neighborhood, and we have opened some neighborhood hubs where we are doing health coaching, connecting to care, and doing some screenings for the population. The other thing that we have been very successful in is that community and patient engagement. We are not only trying to do the patient outreach, but actually engaging the patient. And so we recently had an annual meeting where we brought in everybody from providers, health systems, to community-based organizations, to the patients themselves. And we had a panel with patients and what they shared. So we were learning and leaning and listening to the patients. I've also have heard throughout the day mentioning the mapping. We are working and have created a geospatial mapping that we have as a resource on our website, and we with resources that are out in the community, so that way that the people that are boots on the boots on the ground kind of have resources available to improve healthcare of that community. So let me see what else. I think we're working not only with the obvious partners in creating learning collaboratives, but we have really thought outside the box. And we even have organizations like the EMT and first responders joining us, because of course we know from a cardiac and health events, they're the first ones out there. So we are really working with them, in addition to the educational, to the school systems, particularly in Shelby County. So those are some of the biggest successes I think we have had. And I'll be staying for a few, for a little bit for Q&As after. And that's it for me. Thank you.
Thank you, Gladys. Very glad to hear what you're doing. All right, next up, we have Carla Alvarado, the Director of Research at the Association of American Medical Colleges Center for Health Justice.
Thank you so much for having me. I wanted to share that at the center, we view health equity as a destination and health justice as the path on that journey. And in our stride toward that journey, we plant one foot in community wisdom and multi-sector partnerships, and we plant the other foot on research to inform policy action. And so the Center for Health Justice was an early adopter and champion of the vital conditions, where Bobby Milstein and Dr. Philip Alberti have coincided at the National Academies, and I was able to meet them both there. And so since its inception, we welcome the vital conditions as a framework. Our center addresses several of the vital conditions, including belonging, civic muscle, a thriving natural world, and basic needs for health and safety. And one example of the way we incorporate the framework in our health equity and justice work is through our nationally representative public opinion briefs, where we anchor our findings in relation to the vital conditions. And so we aim to disseminate those conditions to our general public outside of the confines of academic medicine. And examples of the topics that we have pulled on are the public sentiment on trustworthiness, reparations, environmental justice, climate change, and civic engagement. And on these last two, climate change and civic engagement, we've incorporated the voices of the youth to the point that was made in the second panel, where it's important to pretty much foment that civic engagement muscle since early. So thank you so much. The framework has been very helpful to us in disseminating what we all aim to do, which is improve the health and well-being of the population. So thank you so much.
Thank you, Carla. Bobby, it's I can't think of many organizations who are more influential when it comes to healthcare system change than AAMC. So I don't know if you share that perspective, but it seems to me their work is really important as we're working to turn a very large ship.
Yeah, I mean, I have immense admiration for any organization that takes this personally in terms of how are we fitting into the bigger ecosystem and a bigger evolution of our understanding of this. The Center for Health Justice at AAMC is, from my view, is not only, asking some of the most relevant questions and gathering data, in answer to really frontiers of the field, but is also in a position to change the way we socialize new generations of people into this work. What do they need to be competent at? Trustworthiness is something to be built and earned. And so there's no accident that the skill sets and the research questions and the practice innovations policy that's coming out of that center is really helping to reimagine and reinforce what is the best of what this work can look like. We are very far from our best. And I just have great admiration for what Carla and Philip and the team, I don't know, thousands of collaborators really, who are actively trying to find that path toward justice.
Thank you. Thank you, Bobby. Next up is a very good friend of the National Forum. I think someone who has participated in more National Forum meetings than I have, and that's Sunita Sonidodani, the founding director of the Center for Health Research at the Illinois School of Medicine, Peoria's campus, or Illinois' Peoria campus. There we go. So as I untie my tongue, please give us an update of what you're doing, Sunita, related to the vital conditions.
Of course. Thank you, John. It's always a pleasure at the National Forum. Before I give my 2 cents, I want to, to say 2 things. One is Julie has given me 2 minutes. Okay, so I'll take 2 minutes. And the second thing is I want to echo what Bobby said about AAMC and Carla, kudos to you. I also had the pleasure of working with AAMC team with Dr. Philip Alberti for developing the health equity inventory and then pilot testing the health equity inventory. So Eastern Virginia Medical School, my former institution, we were one of the 6 institutions that were involved in piloting the inventory. So kudos to AAMC. Again, thank you very much. I have moved here, John, as you know, in Illinois last year. And I think the topic that I'm going to bring up in the next, 60 or 90 minutes is very much aligned with the discussion that we had in the third panel, and that is the power of data and leveraging the data for improving health. And this is actually heart failure. So when I moved here, I think one of the major tasks of my center, which is a new center for health disparities called Center for Health Research. And the word "for" in my center basically represents informatics, analytics, population health, and health disparities. So we worked with 2 healthcare systems. OSF is the largest healthcare system, and the second is Carl healthcare system. One thing that was we observed, when I took the office, was the huge heart failure readmission rates. So what we have done is from the center, 2 things. Based on the data of the last 3 years of all heart failure patients, and we have got the funding. We got the funding from OSF. We are developing an AI model that can predict high-risk patients who are at high risk for readmissions. So this model that we are developing, taking this 3-year data of all the patients who were discharged with heart failure diagnosis, we are collecting the information not only on the EMR records or claims data or pharmacy data, but we are also intervening to collect the social determinants, for example, information on literacy variables, social support, and all other those variables. The goal is to put this into the model and predict the 30-day readmission rates. And then people who will be at a high risk, they will be triaged to a more optimal, aggressive heart failure treatment. So that is number 1. Number 2, all these heart failure patients who are getting discharged, and before they get discharged, we are also making sure that we assess their mental health. So every patient before the discharge gets a screening for anxiety and depression. And we give them GAT-7 and PHQ-9 questionnaires. And those who show the scores of anxiety or depression or both, they are directed to a cognitive behavior therapy program that is available here in the hospital care system. Online, it is called as Silver Cloud. So it's like killing 2 birds with 1 stone. Transition of care is a huge problem at many healthcare systems, and mental health is one of the complications of poor transition of care. So we are hoping that through the AI integrated predictor, we can identify high-risk patients, but at the same time, anxiety, depression, new cases of anxiety, depression due to heart failure, due to admission, can be directed to an online cognitive behavior therapy while they wait to meet their primary care physicians or their psychologist or psychiatrist. I'll be
Dr.
happy to put my...
Congratulations on that work. And it's exciting to hear how you're tying mental health together with physical health. And that ties us back to the observations that Bern Melnick made during the first panel about the interplay between mental and physical health. And gosh, we know from what you just said, or even predating that, how closely tied heart failure outcomes and success in treatment is with mental health. So congratulations on that work. We'll be eager to hear about the progress.
I will put my link in the chat box. Thank you so much, John.
Thank you. Next up, we are pleased to have Shebra Hall, the Chief of the Bureau of Chronic Disease at the Delaware Division of Public Health. Ms. Hall.
Hi, good afternoon. Yes, it's for Hall. We heard a little earlier from our Chief of the Bureau of Health Equity, one of my colleagues. So just thank you for the opportunity. I think I really can't say a whole lot more than that hasn't been said already. I just wanted to share that in Delaware, as Sequoia mentioned, as a state, we are at that point where we're ready to move to the vital conditions framework. And I think Dr. Milstein, you said it earlier in the first panel, we've been rooted in the social determinants of health, and we're ready to mature to that next level where we can roll up our sleeves and get some additional work done on how to address the social determinants of health. So that's kind of the frame that I'm coming from it at, is how similar the way that we're addressing our helping our population improve health outcomes. And in the Bureau of Chronic Disease, one easy example, of course, is looking at access to healthcare and comparing that to the basic needs as a vital condition. So obviously, we know how important access to healthcare is. However, we're taking that next step. And again, from the first panel where Dr. Sahat eloquently put that we've embraced our journey through social determinants of health, and we have this shared vision. And now we're giving the opportunity to the community to lend their voices and how we can help improve cardiovascular health and improve other health outcomes. And again, Sequoia mentioned one of the activities in our Bureau of chronic disease around the learning collaborative that we just started this year. And we're really excited to move forward with that. And again, that's a perfect opportunity to hear from our community partners, our community members, and how we can improve health, cardiovascular health in Delaware. So I really just wanted to share how we have embraced the vital conditions framework, and we're using it through our social determinants of health lens now that we've matured in that phase. So thank you again for having us.
Catching fire, Bobby. All right, well, running the anchor leg of our relay here is our friend Meg Metter, who is the Director of Quality Improvement and Integration at NAC, the National Association of Community Health Centers. Meg.
Thank you so much, John, for this opportunity. And boy, I've really been challenged today in my thinking. So I thought I'm still going to do this. I want to share that NAC's work in cardiovascular health with community health centers has always been sort of rooted in the social determinants of health. As Shebra said, we develop our implementation strategies for evidence-based interventions grounded in that awareness and consideration for the social, economic, environmental circumstances of our patients. We recently concluded our Improving Blood Pressure Control in African Americans project, which included assessing basic needs such as food security and transportation, along with insurance and income status. And we tailored treatment approaches. So for example, we don't prescribe diuretics to somebody that takes 3 buses every day, learning those kinds of ways to be holistic in our care. And then of course, connecting patients with the community support services we needed. And we're excited to share that preliminary results show we were able to close the disparity gap in hypertension control in those participating centers. And then I wanted to also quickly share in another more exploratory project we did with Alliance Chicago, which is a health center control network. We worked together to create a data model that brought together cardiovascular risk and social determinants of health data at the point of care, actually both for population health efforts and then also informing that holistic treatment. So as I'm excited to share those with you, I think as Jasmine said earlier, how can we do more and be better? And I think for NAC, a next step is really challenging ourselves and exploring how to leverage the vital conditions framework. So thank you.
Thank you, Meg. Well, yeah, not just Meg. Thank you, Meg. Thank you, Sony. Thank you, Shebra. Thank you, Carla. Thank you, Gladys. We appreciate your contributions. Bobby, Meg's last comment about how can we do more reminded me that in population health, where we frequently are confronted with the challenge to do more with less. And it seems like each year we have to do even more with even less. And I'm wondering if you've observed any changes in that dynamic with the vital conditions, that wondering, do conditions help those of us doing this work draw in not only more partners and collaborators, but attract new or different additional dollars and resources?
Yeah, it's a great question, and I think I can hear the collective groan across the world when people say do more with less. It's like it's a joke, and it's often met with the response of I'm too busy to even get help. And so one of the things that this vital conditions framework helps us recognize is that the way we work and with whom matters significantly, right? If you start connecting your work with others and bringing more people who aren't feeling connected at all into it, feel like they belong, feel like their contributions matter, it actually amplifies, grows the pool of assets that allows us to be able to do more things. It's not with less. It's actually means by which we can do things that nobody can do alone. And that hasn't normally been visible or valued or investable, but the vital conditions framework is really sort of codifying insights from savvy practitioners going back, millennia really, but decades, that have shown that when you invest in genuine trusting relationships, when you expand that circle of who feels that they're part of it with an equity agenda, a racial justice agenda, suddenly assets are not the problem. It's really about the ability to coordinate, work well together, negotiate priorities, make investments that are going to yield even more investment. So the dynamics of growing belonging civic muscle are very modern too. It's one of those assets in the world. Like some assets, you can build a monument in one part of town and you don't have any money to build it on the other part of town. Belonging civic muscle doesn't work like that. The more you use it, the bigger it gets. It's part of the sharing economy. It's part of the other thing, knowledge economy, right? And so that dynamic has been invisible to a lot of people who are thinking about transactional programs and projects. But if you're into movement building, then you already know that you're not doing more with less. You're doing more with more people and more talent, and we can accomplish great things.
Well, Bobby, you just said something that was very quotable. The way we work and with whom matters. That certainly is the case every day for the National Forum, not only because we're an organization of organizations, but we see the power behind what you just said, a very pithy comment. We see it every day, and it plays out in impact that is disproportionate to the limited resources that we and partners are able to bring to bear. So yeah, you're right, Meg, you're right about accomplishing more through collaboration. Gosh, there've been so many quotable comments throughout the day. In fact, we'll be making those available, and we'll be making not only recordings of all of the panels and Q&A segments available on the National Forum website in the next couple of weeks. We also will be making transcripts available. So if it's easier for you to find some of those great ideas or brilliant insights by using a transcript, that'll be available to you as well. So please watch your inbox, because you'll be getting a follow-up message from the National Forum letting you know that we've posted those resources and they're available not only to you, but to any of your colleagues with whom you want to share them. And we hope you will encourage those who weren't able to participate today to take in all these great learnings at the convenience of their schedules. So thank you all again for sharing how you are employing the vital conditions in your settings and how you're strengthening them. It's really interesting to hear that translational experience. Thank you all for your valuable insights. Your contributions really do enrich all of our understanding and provide us with inspiration to continue striving to improve fair opportunities for everyone to attain optimal cardiovascular health and good health and well-being wherever they live.
I now call the National Forum for Heart Disease and Stroke Prevention's 2024 annual business meeting to order. Members will vote today on two matters: the approval of the Treasurer's Report and the election of directors. Each National Forum member organization has one voting representative. Voting today is via a poll question on your computer screen. If you're a National Forum voting representative, please vote. There will be 15 seconds to submit your vote on each question. If you have new business to bring before the membership, please use the chat function to bring it to the chair's attention before Dr. Melnick calls for the new business at the end of the meeting. For today's virtual meeting, the Zoom events attendance record will be used instead of a live roll call of members. Minutes from the October 26, 2023 annual business meeting are in the program book. Does anyone have any corrections? If yes, please place them in the chat box. If there are no corrections, they will be automatically approved by being on the consent agenda. We have no changes in the chat box, thus the minutes are approved. Mike Kropp will now give the Corporate Operations and Finance report.
Thank you. It's my pleasure to deliver the Treasurer's Report. And on the slide, you can see with the various accounts that we have a total cash and receivables of $2 million and roughly $132,000. Now that equates to about 13 months of operating expenses. So we're in a very strong position with our cash and receivables. If we go to the next slide, this outlines where we stand with our cash and receivables on the balance sheet in 2024 relative to 2023. And you can see that we're a bit behind where we were in 2023. And as we look to the changes in the net assets between 2024 and 2023, what we're seeing is that there's been a significant change in the revenues coming in 2024 relative to 2023. This is largely due to a significant grant that we did not receive from the CDC that we had been expecting, and some timing with respect to corporate contributions. So we are behind where we stood in 2023. But if we go to the next slide, we know that with the National Forum, the differences month to month and year to year are often a reflection of the timing of the revenue flowing in and the expenses that we have. So as I mentioned, in our position of cash and receivables, we're still in a very, very strong position. And we have a number of grant proposals out there that will hopefully begin to make up some of the gap that we see between 2023 and 2024. So that concludes my report, and I will make a motion to accept the Treasurer's Report as presented.
I second the motion.
I'd like to now call for approval of the Corporate Operations and Finance report.
Okay, voting polls are open. Hope be open for about another 10 seconds. Please register your vote. Calling for last votes, please. And voting is closed. Here are the results.
Great, we have the results, and I now this item is now approved.
We will now move to the Executive Director's report.
Marcus Plesha covered many of the past year's key achievements in his report, and Mike Kropp covered the National Forum's financial health in the Treasurer's report. I will not take your time to repeat that information. Instead, the Executive Director's report will focus on the National Forum's future direction. Working together multiplies our collective strength. That is both the function and strength of the National Forum. We gain further strength with the addition of 6 new members in 2024. Aledade, the City of Streator, the Kansas Pharmacists Association, the Medical Fitness Association, the National Fitness Campaign, and the Village of Maywood. You heard in the Association of Black Cardiologists video that our joint policy statement on expanding people's access to care has contributed to 32 states enacting 75 policies. We are updating that joint policy statement and expect this refresh in advocacy by the Value and Access Collaborative to result in more policy changes in 2025 and 26. The Value and Access Collaborative recently released a new co-branded shared decision-making guide on atrial fibrillation. We will mount a dissemination and implementation campaign into 2025. The National Forum will continue to provide briefings on timely issues affecting cardiometabolic health and health equity. For example, last month we held a briefing on the 340B drug pricing program, an under-the-radar program that affects healthcare access for underserved communities. Attendees said the briefing significantly increased their understanding of the program and issues. That increased understanding will enable more stakeholders to add their voices to discussions about the 340B program and propose changes to it. We will continue to expand Move with the Mayor to empower more people in more communities to attain good cardiometabolic health. The 2 things that excite me about Move with the Mayor are, first, it demonstrates that population health transcends partisan divisions. We involve Republican, Democratic, and nonpartisan mayors in urban, suburban, and rural communities. They're rowing in the same direction, aligned with the vital conditions for health and well-being. Through Move with the Mayor, they are taking action to give everyone a fair opportunity to make healthy choices and attain health and well-being. Second, we work with mayors to implement evidence-based policies, programs, and environmental changes. Cities that report data to us have implemented an average of 9 community guide interventions. Because the interventions are in the community guide, we can extrapolate their magnitude of impact. For example, a systematic review of evidence found that providing social support interventions in community settings leads to a 44% increase in time spent being physically active. Data provide information that makes a case. Stories humanize that data and motivate policymakers and other decision makers to act. Move with the Mayor produces compelling real-life stories about evidence-based interventions to improve cardiometabolic health. I'm pleased to report that your National Forum is 88% of the way toward it reaching its White House challenge goal, even though the deadline is December 2025. As issues arrive that affect people's opportunities to attain health, the National Forum will continue to collaborate with trusted messengers to illuminate the facts about these issues. For example, we have amplified mayors' and clinicians' voices about how pharmacy closures affect underserved communities. In the real world, that advocacy translates to bipartisan support for legislation that would expand people's access to vital healthcare services. One such bill, ECAPS, may be included in a legislative package in Congress's lame duck session. The board of directors, including the new members you will elect in a moment, will update the National Forum's strategic plan for 2025 and 26. Finally, thank you for your involvement in the National Forum. It exists to help you accelerate your organization's achievement of its goals related to the National Public Health Action Plan to prevent heart disease and stroke.
In a moment, voting representatives will be asked to vote on the nominees for 2-year terms on the National Forum Board of Directors. You will vote in the pop-up window on your computer screen. The Governing Committee and Board nominate the following slate of candidates for the Board of Directors for a 2-year term from 2024 to 2026. If you're a voting representative of a National Forum member, please vote in the pop-up window on your screen. Dr. Robert Hilkert, Dr. Maureen Litchfeld, Dr. Modele Oganiyi.
Okay, voting polls are open. They'll be open for about another 10 seconds. Please register your vote. Calling for last votes, please. And voting is closed. Here are the results.
Great, thank you. We now have a slate of Board of Directors. Please note the Board of Directors elected the 24-26 officers on October 3rd, 2024. Dr. Bern Melnick will now become your chair. I will become the past chair. Dr. Mike Kropp was elected as the incoming chair, and Dr. Celeste Phillip was elected as the Secretary-Treasurer.
The National Forum Honors 2024 Awards. I'm Julie Harville, and I'm joined by Stacy Resendez. The National Forum normally recognizes individuals and organizations who have made exceptional contributions to heart disease and stroke prevention. We are sorry we are not all together in person. However, we have received acknowledgments from the award recipients whose remarks we will share with all of you. The National Forum has presented 101 awards since the program began in 2009. Today, we will present 6 new awards. National Forum Heart Healthy and Stroke Free Award, presented to an individual whose work embodies the recommendations of the National Public Health Action Plan to prevent heart disease and stroke. Dr. Lawrence Sperling.
Your leadership, work in Million Hearts, and teaching have been instrumental in advancing public health initiatives. Your commitment to promoting heart health has had a profound impact on reducing preventable heart attacks and stroke across the U.S.
I'm humbled and honored to receive the National Forum Heart Healthy and Stroke Free Award on behalf of many. The Million Hearts team, partners, and inspirational individuals dedicated to the prevention of heart attacks and strokes across the nation. I'm truly grateful, and this is such a special honor. Thank you so much.
National Forum Heart Healthy Stroke Free Award is presented to an organization whose work embodies the recommendations of the National Public Health Action Plan to prevent heart disease and stroke. Hearts of Sonoma County.
For exceptional collaboration in preventing cardiovascular disease and stroke in Sonoma County by uniting over 20 organizations, sharing best practices, and developing innovative strategies, Hearts of Sonoma County significantly improved blood pressure control during the COVID-19 pandemic. Your commitment continues to save lives and advance health equity. Accepting the award is Dr. Monica Ferguson.
I'm very honored to accept this award on behalf of Hearts of Sonoma County. We are a collaborative between both healthcare organizations and community-based organizations that has been meeting monthly for 10 years now to try to reduce cardiovascular disease in our community. So I would like to thank all of our members for their work. And we hope we can be an inspiration for other communities to prevent heart attacks and strokes across the nation. Thank you.
National Forum Public Policy Award recognizes an individual who has been effective in advancing policy change that reduces the heart disease and stroke burden on a national, state, or local level. Mayor Aquanetta Warren.
For leading Fontana's investments in evidence-based infrastructure improvements to make active transportation accessible to more people, including students and underserved residents.
I am ecstatic about receiving this award. This means so much for me. Through the years, and I mean a couple of years, I have been working very hard with the United States Conference of Mayors and other groups to make sure that the bipartisan infrastructure bill was passed. But having the pleasure of being at the White House when President Biden signed that particular legislation and being allowed to speak and covering for all the governors and mayors, there has not been anything in my life in a long time that exciting. But what's more exciting is the great work we as a city have done to connect people through the right ways, not just car activity, but bike lanes, walking, having presentations, and we will continue to do that program because it works. We at one time had a large obesity level for our children, and I'm happy to tell you our baseline is going down, which means we're teaching our public the right way to eat. And more importantly, we're using our facilities all over our city to make sure people are engaged in healthy activity.
National Forum Public Policy Award recognizes an organization that has been effective in advancing policy change that reduces the heart disease and stroke burden on a national, state, or local level. American College of Cardiology.
For ACC's exceptional collaboration and leadership to advance evidence-based policies that enhance access to cardiovascular health and improve equity.
I'm Dr. Richard Kovacs, the Chief Medical Officer for the American College of Cardiology. The ACC is honored to receive this year's Public Policy Award from the National Forum for Heart Disease and Stroke Prevention in recognition of our ongoing work to advance evidence-based policies and enhance access to cardiovascular health care and improve equity. Ensuring patient access to the right care at the right time is key to achieving the mission of the American College of Cardiology to transform cardiovascular care and improve heart health for all. On behalf of the ACC, thank you for this award.
National Forum Commitment Award, given to an individual who has made outstanding contributions to the National Forum. Dr. Marcus Plesha.
For your unwavering dedication, insightful guidance, leadership, and inspiration that have helped strengthen the National Forum's impact on cardiovascular health and health equity.
Well, thank you very much. I'm very humbled and flattered to receive this award. I have really enjoyed my time on the board of directors and as the president or chair of the board over the last few years. I'd say my commitment to the National Forum mirrors the National Forum's commitment to the issue of cardiovascular health and health equity. It's been a real pleasure to work with the other board members and all of the members of the National Forum, and particularly with the staff. It's been a busy and active last couple of years with the National Forum. Everybody has worked very hard, and I think we have a lot to show for that. And I'm very flattered that you all would honor me with this recognition, and I really appreciate it.
National Forum Chair Recognition Award. The Chair's Recognition Award recognizes extraordinary service to improve health equity and optimize cardiovascular health and well-being throughout the lifespan. Dr. Letitia Presley Cantrell.
For your service in the fight against heart disease and stroke and your continued efforts to improve cardiovascular health in underserved communities. Your leadership in advancing health equity and reducing health disparities has made a lasting impact on heart and brain health nationwide.
Good afternoon, and thank you to the National Forum for Heart Disease and Stroke Prevention for this award. I appreciate the recognition for the work that I do to advance heart disease and stroke prevention, or should I say the work that we do, because I do not do this alone. I have an incredible team of public health professionals working with me. But most of all, I carry my late grandmother with me. She is always with me, reminding me that there are so many people, especially women like her, who will benefit from what we're doing to ensure that they have healthier, longer lives. Thank you again to the National Forum for this honor.
Tribute to outgoing leadership. Dr. Warren A. Jones.
For your outstanding leadership and commitment to cardiovascular health and health equity.
Hello, everyone, especially my friends and family from the National Forum for Heart Disease and Stroke Prevention's family. I've really enjoyed working with you this last 9 years, and most importantly, having had the pleasure of serving on the board and as the board of trustees. This honor really touches me deeply, and I want you to know I'll continue to work for our goals no matter what. We know this is personal for me, with my daughter having died from heart disease. I don't want other families to go through what I've been through. So thank you for thinking of me during this time. Thank you for honoring my service, and I wish the best to everyone.
Incoming leadership. 2024-25 National Forum Board of Directors. Officers and Executive Committee members. Dr. Bernadette Melnick, Chair. Dr. Michael Kropp, Vice Chair. Dr. Celeste Phillip, Secretary Treasurer. Dr. Marcus Plesha, Immediate Past Chair. John Clymer, Executive Director.
Emeritus Founder, Dr. Darwin Labarth. Counsel, David Zook. Scientific Advisor, Dr. Stephen Sidney.
Directors: Juliana Crawford, Dr. Robert Hilkert, Dr. Maureen Lichtfeld, Rosemary McGillen, Dr. Madale Oganiyi, Dr. Ileana Pina.
Federal Liaisons, Elizabeth D., Dr. Lawrence Fine, Dr. Walter Koroshetz, Dr. Brandon Taylor, Dr. Janet Wright.
This concludes the 2024 National Forum Awards ceremony.
I am so delighted to assume the chair position of this fabulous organization that's making such a positive impact across the nation. I would now like to call for any new business. If you have new business, could you please type it in the chat box? No new business has been submitted. So I will now make a motion to adjourn our meeting.
I second the motion.
Without objection, the annual business meeting is adjourned. To conclude the National Forum's 2024 meeting, I pass this on to our terrific Executive Director, John Clymer.
Before we close the meeting, I want to express our gratitude to Dr. Bobby Milstein for deftly leading 3 highly informative panels, and to the panel members. Your perspectives and insights will be valuable to the hundreds of change agents who have heard you today. Thanks to our partners at the American Heart Association, the American Pharmacist Association Foundation, Boehringer Ingelheim, and Regeneron for sponsoring the meeting and your no-cost participation. Many of you have put on conferences and meetings, so you appreciate the work that goes into a successful one. I want to recognize those whose behind-the-scenes work has translated this meeting from the drawing board to reality. Julie Harville led the planning and preparations for this annual meeting, and Stacy Resendez and Whitney Weber organized the panels, registration, communications, and more. And John Bartkus produced this virtual meeting, smoothly stitching together its many moving parts. In the spirit of continuous improvement, please take a moment now to provide feedback on this event using the survey link in the chat box. Your evaluations and comments last year helped shape today's program. We will weigh your evaluations today heavily and use them in a similar way. Finally, we've heard from change agents who have used data in the Vital Conditions for Health and Wellbeing framework to create and strengthen opportunities to attain health in different types of communities and regions throughout our country. What idea or example will you implement?